Keeping this in mind, we have started this teaching program, which we call For the Students, by the Students. In this, mainly the trainees of various disciplines of oncology, surgical, medical, and radiation would be presenting their aspects of their therapy, as well as have case discussions, and they will be supported by some senior mentors who will keep guiding them and correcting them. So keeping this in mind, this is the first lecture of this series. Our president of Society of Oncology Forum, Dr. S.V.S. Dev, who is also head of the Department of Surgical Oncology at AIMS, has also joined us. May I invite Dr. Dev sir now to say few words of to inspire everyone.
Thank you, Vineeta. A very good evening to all. This is actually a long pending event which we have been planning, as Dr. Vineeta has said. Mostly the events are being organized by faculty, but we thought we should do something for the students. And this initiative was taken by Dr. Vineeta and Dr. Kanika Sood. In this series of events, we are going to start the first event based on the oral cancer. And there is an eminent panel of senior experts, including Dr. Kapil Kumar and other faculty to mentor the students. So I would like to, without wasting time, I would like to hand over the stage to Dr. Vineeta to start the proceedings. Thank you. Thank you, Dr. Vineeta. Let's start the program. Thank you.
So the first session that we are going to start with is about the surgical aspects of tongue cancer surgery. The mentors and discussants for this session are Dr. Kapil Kumar sir, who is head of Director of Surgical Oncology, Fortis Hospital, Delhi. Dr. Saurabh Arora, consultant in head and neck surgery at Max Hospital, and Dr. Shilpi Sharma. Dr. Shilpi Sharma is also consultant in head and neck surgery. The speaker for this talk is Dr. Haresh. He's a Dr. Haresh Marana. He's MCH trainee from Department of Surgical Oncology, All India Institute, Delhi. So may I request Dr. Haresh to kindly start with his presentation.
Library. Good evening, respected teachers and residents. And I would like to start the first topic in Oncology Forum. And the topic allotted to me is surgical aspects of tongue cancer surgery. I'm working as an MCS trainee in Department of Surgical Oncology at AIMS under the guidance of Professor S.V.S. Dev sir. My slides. Let's start with the anatomy. First, we'll start with the muscles of the tongue. We have the intrinsic and extrinsic group of muscles. The extrinsic group of muscles alter the position of the tongue. They are the genioglossus, which maintains the bulk of the tongue, and protrusion of tongue moves the tongue from side to side. The hyoglossus, which depresses the tongue. The styloglossus, which creates central furrow with the genioglossus during swallowing. And the palatoglossus, which elevates the posterior aspect of the tongue. The intrinsic muscles alter the shape of the tongue. They are the superior longitudinal, inferior longitudinal, transverse, and the vertical group of muscles. The arterial supply is principally from the lingual artery, which is a branch of the external carotid artery, the dorsal lingual artery, deep lingual artery, sublingual artery, and minor contributions also from the tonsil and ascending pharyngeal arteries. The venous drainage is through the dorsal lingual veins, deep lingual veins, which join to become the sublingual veins, and all of them drain directly or indirectly into the IJV. The nerve supply is different in tongue compared to other organs. All the motor muscles are supplied by the hypoglossal nerve except the palatoglossal, which is supplied by the pharyngeal plexus through the cranial part of spinal accessory nerve. The sensory to the anterior two-thirds of tongue, the general sensory is by the lingual nerve, and special sensory taste is via the chorda tympani from the facial nerve. The general and special sensory to the posterior one-third of tongue is through the glossopharyngeal nerve. And with the lymphatic drainage, which is very important in tongue because it is a very vascular organ, muscular organ, and high propensity for lymphatic spread, and high propensity for skip metastasis. The reason being, if you see along the lateral view, the sagittal view. You can see from the tip of the tongue, the lymph node drainage is to the submental nodes, and from the mid part, it goes to the submandibular nodes along the lateral aspect, and posteriorly it goes to the jugulodigastric and jugulo-omohyoid nodes. If you see from the superior aspect, you can see there is crossover of lymphatics along the middle part of the tongue.
I think we need to mute all the speakers, Nidhi.
Sir, I'm doing, but there are two speakers who I'm unable to mute. Dr. Jyoti Sinha.
Yeah, because there's a lot of echo and
Yes, sir.
disturbance coming. Yeah,
Yes,
please.
sir. Yes, sir.
Yes, Harish, go ahead.
So if you see the lymphatic pathway from the superior aspect, you can see there is a crossover of lymphatics along the midline, and there is also lymphatic spread to the level 2 and level 3 lymph nodes. So as you go posteriorly, there are high chances of level 3 lymph nodal involvement even before level 2 or even level 1A and 1B. So tongue cancer constitutes 34% of all oral cancers. The sites 75% occur at the lateral border of tongue, 25% occur in the ventral surface. The Indian statistics, as per NCRP, it is the fourth most common cancer among the males, 5.9%, excluding the other oral cancers, of course. And the estimated incidence in 2022, male is 41,845 and female 14,611. So regarding the principles of tongue cancer surgeries, the first and foremost is resection with adequate margins, which we will discuss in a while. And the gross margins arbitrarily assumed, arbitrarily kept as 1 centimeter and pathologically 5 mm. The preservation of adequate volume of tongue for speech and swallowing, securely ligating lingual artery, and addressing the neck either to an ESHND or MND bilateral neck dissection, which we will be discussing soon. And reconstruction, we have to reconstruct bearing in mind the shape of the tongue and the function of the tongue, reconstructing the floor of mouth if resected. The glossectomy techniques. So first, while doing surgery, we do the marking. We give 1 centimeter margins. The marking, incision marking is done by cutting cautery, and the resection is done by coagulation cautery. And the lingual artery ligation. So there are various levels at which the lingual artery can be ligated, which we will be discussing. And if you are going for a wedge resection, we preferably go for a transverse wedge resections for early lesions because it is functionally better and prevents a serpentine deformity when you do a longitudinal excision, and it also interferes with speech and mastication. With respect to the surgical approaches, the most commonly used approach is the transoral approach. However, if the patient is having severe submucosal fibrosis, it may not be feasible, or lesions posteriorly may not be approachable. The paramedian mandibulotomy approach is commonly done. Then there is the visor flap approach, the lower cheek flap approach, and upper cheek flap approach. Transoral mandibulotomy approach and visor flap are the most common procedures for approaches. The types of glossectomy. This article is from Dr. Jatin Shah from MSKCC. The type 1 glossectomy includes mucosectomy, in which mucosa and submucosa are removed. And these are usually not preferred for proven malignant cases where the suspicious malignance or in leukoplakia kind of lesions. This is being done. Type 2 glossectomy is the partial glossectomy in which mucosa, submucosa, and intrinsic muscles up to the surface of extrinsic muscles are removed. In type 3A glossectomy, known as hemiglossectomy, the specimen includes the mucosa, submucosa, intrinsic and extrinsic muscles ipsilateral to the lesion. Type 3B is known as compartmental glossectomy. In addition to 3A, the lingual nerve is resected as far cranially as possible, and the hypoglossal nerve is removed after the ansa, and the lingual artery and vein are ligated at its origin. Type 4A is known as subtotal glossectomy, when there is preservation of both sides of the base of tongue and the entire anterior 2/3 of tongue is removed. In type 4B, there is ipsilateral base of tongue is also removed in addition to subtotal glossectomy. And type 5 includes a total glossectomy, in which a specimen includes all of the mobile tongue, base of the trunk, transected at the level of vallicula, intrinsic, extrinsic muscles, both lingual arteries, hypoglossal, lingual nerves, and floor of mouth. So the indication of mandibulectomy in tongue cancer surgeries, when there is infiltration of the mandible, cortical or mandibular, cortical or medullary erosion, abutment with the alveolus or mandible in an edentulous patient to obtain adequate margins, or if the patient is already having underlying pathological or any other fracture in the mandible. So if indications for margin mandibulectomy for margin clearance with even without any infiltration, a dentate mandible when there is abutment with the alveolus, but the patient is a dentate mandible. So we commonly perform horizontal margin mandibulectomies. On occasion, vertical mandibulectomies may also be required. The inoperable criteria for carcinoma tongue is when there is internal carotid which are not amenable to resection with adequate margins, or oropharyngeal involvement like piriformis PFS involvement. Regarding the widely debated topic in head and neck cancers, the optimal margins specifically for CA tongue. So this article is from Tata Memorial, Mumbai, and this article was published in 2020, in which they would like to redefine the margin status rates. So this article, they retrospectively studied 451 patients. As per their study, they considered 0.0 to 2 mm microscopic margins as positive margin. Group 2 from 2.1 to 7.5 mm were called close margins, and group 3 more than 7.6 mm were classified as adequate margins. The reason being, for every millimeter margin increase provided a mean of 3.67 months survival advantage from 2.1 mm to 7.5 mm. However, after 7.5 mm, if the margin is increased, then there is an advantage of 15 months in overall survival. So they considered 7.5 mm to be the ideal margins. Another article which is contradictory to this, this was done from MSKCC. It was published in 2017, and as per this article, they have studied 381 patients. It is a multivariate model adjusting for all pathological factors, and as per the results of their study, patients with positive margins and those with margins up to 2.2 mm had similar outcomes with respect to local recurrence-free survival. So they wanted to redefine close margins, meaning to 2.2 mm, not 5 mm. And the role of frozen section for evaluation of margin status in head and neck cancers. Being in the field of oncology and surgical oncologists, our primary worry is how good a margin we have rather than a positive margin, as positive margins is not acceptable in carcinoma tongue. And for this article, they have studied 1,796 pairs of frozen section were analyzed, and the sections were studied by a pathologist with 10 years experience. The frozen section adequacy has been reported of 97% with a sensitivity and specificity of 98%. The discordant rate for margin status is 3.1%. So with that, the margin status only 3.1% of benefit they were able to obtain. Coming to the surgical aspects, the identification of lingual artery. The lingual artery is encountered in between the fibers of the hypoglossal muscle when you're doing the resection of the tongue. And if you want to resect the ligate the lingual artery proximally, then you go, you look for the lingual artery in the Pirogov triangle. When you do neck dissection, it is bounded by the intermediate tendon of digastric muscle, posterior border of mylohyoid muscle, and the 12th cranial hypoglossal nerve. The Blakelyard triangle is bounded posteriorly by the hyoglossus muscle, posterior belly of digastric, and greater horn of hyoid bone. You can also ligate the lingual artery from its origin itself by exposing the carotid sheath, external carotid artery. The first branch which arises medially is the superior thyroid artery. Then the third branch is the facial artery. In between those two, you can identify the lingual artery. And whenever we see the lingual artery, it cannot be cauterized. It has to be ligated or even doubly ligated. Neck dissections in CA tongue. Whether to do neck dissection or not. if necessary, then what type of neck dissections? Like extended supraomoid neck dissection or supraomoid neck dissection, MND, RND. Whether SLNB has any role. Ipsilateral versus bilateral neck dissection. So in SOHND, we remove levels 1A, 1B, 2, 3. In ESOHND, we remove, in addition to that, level 4 also. In MND, level 5 is removed with preservation of spinal accessory nerve, IJV, and sternocleidomastoid muscle. In RND, all those structures are sacrificed. So this is the famous article by Dr. Anil De Cruz from Tata Memorial Hospital, which was published in NEJM. Elective versus therapeutic neck dissection in node negative oral cancers. This was a prospective RCT. An elective node dissection, meaning ipsilateral neck dissection done at the time of primary surgery versus therapeutic node dissection, in which patients had watchful waiting and they had a neck dissection when they had nodal relapse. So 500 patients were analyzed, 245 in the END and 255 in the TND, therapeutic neck dissection. At 3 years, END resulted in improved overall survival of 80% compared to 67%, statistically significant. And END also had a higher rate of disease-free survival, 69% versus 45%. The adverse events were 6.6% compared to 3.6% in view of local issues, perioperative morbidity. Another systematic review and meta-analysis comparing elective neck dissection versus observation in early stage carcinomas of tongue. It was published in JAMA of Head and Neck Oncology, 2016. 20 retrospective and 3 prospective RCTs were analyzed, 3,244 patients. END significantly reduced the risk of local recurrences and improved disease-specific survival rate compared with management by observation. However, as per this article, the END did not significantly improve the overall survival. So with these 2 articles, we have a conclusion that neck dissection has to be done for all head and neck cancers, particularly for tongue. The role of SLNB in tongue cancers, neck dissections based on sentinel lymph node navigation. As per this study, which was published in Journal of Clinical Oncology, which is under ASCO in 2021, it was a multicentric RCT done in Japan. T1, T2 lesions with node negative and depth of invasion more than 4 mm, as the chance of lymph node spread increased with more than 4 mm, were randomly assigned to undergo standard neck dissection or SLNB navigated neck dissections. The SLNB dye they used was technetium 99 radiocolloid, and as per their study, the evaluation sensitivity of frozen section was only 68%. So false negatives were present in 32% of their patients. Another point to note in this study was that they had sent the benchmark of non-inferiority to 12%, and they compared SLNB and selective neck dissection. In the SLNB group, the 3-year overall survival was 87%, and in neck dissection, it was 86%. Although these both are similar, because of the non-inferiority criteria, it was significant statistically. The 3-year disease-free survival was 78% in SLNB group and 81% in the neck dissection group, which was again statistically significant. The neck functionality test, in which they tested the stiffness, pain, drooping, abduction test, and numbness at various time periods, were better in SLNB group. So coming to bilateral neck dissection. So bilateral neck dissection is done if there are clinically involved contralateral lymph nodes, lesion crossing the midline with or without lymph nodes, lesion is less than 5 mm from the midline, as we saw in the anatomy picture, that is crossing over of lymphatics and in the medial aspect. Lesions at the tip of tongue, and level 1A lymph nodes are also considered by some for lymph node dissection in the contralateral side. Reconstructive procedures. So after removal of the tumor, leaving behind a raw area in the tongue, there are people who do not do any form of reconstruction. This exposes the lingual arteries to bleeding. We can also do an SSG. There is a nasolabial flap, a pedicle nasolabial flap, or a random flap, some submental flap, platysmal flap, PMMC flap for floor of mouth reconstruction if it is also removed, and free flaps. This is the last topic in the seminar, the risk stratification. The commonly used is a Brandwin-Gensler scoring, in which they consider the worst pattern of invasion, lymphocytic host response, and the perineural invasion. A score is assigned, and mild, moderate, and high risk is assigned, which predicts the recurrence rates in cancers after surgery. Another study which was done from Amrita Institute Kochi by Dr. Narayana Subramanian, in which they had assessed the adverse pathological features in the final histopath report. Based on this, they gave a scoring system with a margin less than 5 mm having a score of 4, tumor depth more than 4 mm having a score of 2, and an infiltrative margin, poor differentiation, LBI, PNA having a score of 1 each. So patients having margin of 5 mm needed revision surgery. Margins less than 5 mm without any other risk factors, as you see from the table, it will be score 4, they may be observed. Margins more than 5 mm with a total score of 5 may still benefit from adjuvant therapy. Those with margins over 5 mm have improved local regional control. Thank you. I would like to thank Dr. Vineeta Goel, madam, and my Professor Dr. S.V.S. Deo for giving me this opportunity.
So thank you, Dr. Harish. It was a very, very comprehensive presentation, and I think you covered all the aspects. Thank you so much for the efforts that you undertook. I request the mentors, Dr. Kapil sir, Dr. Saurabh Kumar, Dr. Shilpi, Dr. Saurabh Arora, Dr. Shilpi, to kindly proceed with the discussions.
So, hello. Yeah, great. You have covered all the important points. However, I would like to discuss few more things. One is, you said that lingual artery is to be ligated. So, do you ligate? Should it be ligated in all cases who are undergoing tongue surgery? Is it mandatory?
If there is a hemiglossectomy or a subtotal glossectomy, then you will have to ligate. If you are doing an anterior partial glossectomy, predominantly in the posterior aspect or in the middle, then we may not encounter the lingual artery during this surgery.
And
but if encountered,
why do you ligate a lingual artery basically?
It is notorious to cause post-operative bleed.
Yes. So even if when you are doing peroral resection, hemiglossectomy and near total, and obviously for obvious reason you will ligate. So even if you are doing peroral, the tumor is encroaching the floor of mouth, and if we have taken significant cases, it's a good idea to ligate it, because we don't want this to cause secondary hemorrhage. But yes, not in all cases it should be ligated. That is one point. Second, you did not discuss anything about the compartmental resection of tongue. So when do you do compartmental resection of tongue, or what is the evidence? Or otherwise I can discuss briefly.
I think Shilpi, he has given the classification only for the compartment resection, not discussed completely. But I just want to know why the concept of compartment resection, why they have given the concept of compartment resection.
Sir, I'm afraid I could not hear you, sir. Please, you could repeat that question.
I just want to know why there is a concept of compartment resection of the tongue. Why the MSKC has given this concept of compartment resection? Can you hear me?
Yes, sir, I'm able to hear you.
You have given the classification to us that it
yes,
is
sir.
Mucosectomy type 1, then type 2, there are two, then type 3, there are 2 parts, type 4, there are 2 parts, A and B, then type 5 and type. So why there is a concept of compartment section? We were doing adequately with the margin. Why there is a concept there?
Sir, there is any perineural spread or perivascular spread, then resect the entire compartment as a whole.
So there are four things in that. One is lymphatic, definitely lymph nodes. The second is muscles in throat of mouth and towards the floor of mouth of tongue, and the tongue muscles also. Third is the glandular tissues like sublingual gland and submandibular gland. And fourth, what you have told us, that the nerves and the vessels. So in the compartment dissection, you resect all of these together, so that there will be decreased chances of recurrences can be there.
Yes.
When do you do compartmental dissection? So basically, like Dr. Saurabh mentioned, that this is there is an Italian group which have adopted this technique, dissection of the tongue as a whole in a compartment. In the original paper, they actually advocated for even a small lesion. They found that the loco-regional control rate is much superior as compared to the wide excision. But of course, that is not practical, and that is not been replicated by any other group. There is one more paper which have compared wide excision compartmental resection. So they have found, yes, if the lesion is very big, so if you have initial small lesion, you take adequate margin 1 centimeter and all is fine. But suppose if you are doing a hemiglossectomy, if you are removing the one half of the tongue, then you should do compartmental resection where you have to take the extrinsic muscles from origin to insertion. So not just cut the mylohyoid or all these muscles just in the middle, you should ligate it in a sequential manner at the level of the hyoid. So you have to take the lingual artery at the hyoid, you have to cut the muscles at the hyoid. So you take the complete origin and insertion. So that is the basically concept of compartmental resection.
I think Dr. Kapil is there, and we have gone back to the older days with the compartment section. We used to do because not my period, but before that, in the buccal mucosa at least, they used to do complete mandibular dissection with the neck dissection with a single specimen only. And in the tongue, we have reached there only with the compartment dissection now. Am I right, Dr. Kapil, sir? You are there.
I think the functionality also has to be, seen all the time, so that the function of the tongue remains, and we should, stick to the wide local excision in smaller lesions, and if there are bigger
Yes.
lesions, then we should do a compartment excision. And I want to ask him, because he is mentioned about the submental flap, because it is in the same lymphatic area. So I would not like to do a submental flap for any reconstruction in the oral cavity. It is not a good flap to do. So best is to do either not to do any reconstruction if there are smaller excisions, or do a free flap if required.
Another thing is, you just gave us very you just mentioned the name of the flap very quickly in 1 or 2 lines. If you can mention when to do primary closure, when to do skin graft, when to do pedicled or free flap reconstruction, if you could just summarize very briefly.
As if it is an anterior partial glossectomy, and if without go for that, and if there is for either a involvement, and when you resect the floor of mouth, then you either use a nasolabial flap pedicled based on the facial artery, or a PMMC flap to reconstruct that defect.
Yeah, but
I
suppose
think that is not the issue.
partial glossectomy involving the tip of the tongue. I mean, if you have taken just the anterior 2/3 of the tongue, even if it is the anterior partial glossectomy, but you have to reconstruct it because to maintain the functionality. So basically, the general dictum is that if after resection, if the remaining volume is, the defect is less than 1/3, then the primary closure is feasible without causing much functional problems. If there is a volume loss of about 2/3 of the tongue, then you have to definitely supplement it, but you have to use something which is pliable. So if you're doing hemiglossectomy, it's better idea to take either thin ALT, or you do free radial forearm flap. But when more than 2/3 of the volume of the tongue is lost, then you basically, your main idea is to provide the bulk. So there you, if you do free radial forearm flap, it may not be enough. Then you have to do free ALT, or you have to do PMMC, or that kind of flap, which gives the bulk. So as to maintain, little bit of functionality, whatever is possible.
So Dr. Mudit's question is, Dr. Mudit is there, and he can you avoid doing neck dissection, and in which cases?
Excuse me, sir.
Can you avoid the neck dissection in any case? You have told that you have to do. You have shown us 2 studies to do the neck dissection in all the cases. The benefit of it. There any case scenario where you can avoid the neck dissection?
There's a varicose lesion, then we like to go for a surgery initially for the primary, and then reassess the final histopath report. But if it is a proven case of invasive carcinoma, then we have to address the neck. This is what we follow in our institute, and neck has to be addressed.
So you have given us shown us the paper of N0 neck from Tata. Was there any
Yes.
subset of patient where they have not they have recommended that neck dissection can be avoided? If you have read it completely, you must be knowing.
Sir, I might have missed it. I tried to read it fully, sir.
Dr. Saurabh,
think-
this is a teaching session. So in case he's not able to answer this.
Yeah, sure. So if there is a depth of invasion, it's yes, Dr. Mudit is also wrote here, is the depth of invasion is 3 millimeter or less, and there are no other adverse features are there. So in those cases, you can avoid the neck dissection, but it is very difficult to find out the case like that. Sometimes you do the excision of the tongue, small lesion, and margins are all adequate, and depth of invasion is 3 millimeter only, and patient then come to you. Those are the cases, and there is no PNI or LVI is there or soft factor is there, and those cases you can avoid the neck dissection.
So there's just one thing I want to add. So if you read the N0 paper carefully, so this less than 3 millimeter subset, the N0 paper does not say that in this group of patients you may avoid neck dissection, you should avoid. It's basically because the number of patients who had less than 3 millimeter depth of invasion were so less that it is difficult to derive meaningful conclusions that less than 3 millimeter you should do neck dissection or you should not do neck dissection. Now, if you have a patient upfront who is proven squamous cell carcinoma of the tongue, it's better to do neck dissection. There is a retrospective data, I think from Korean study or Italian study again, where they have studied the patients who did not undergo neck dissection at the time of surgery. And they have seen that patients, even if they have 2 millimeter depth of invasion, there is risk of neck failure was still high. So we really, but again, it's a retrospective small subset. We really don't know. But yes, it may be beneficial to follow up the kind of patient where he has undergone surgery thinking it is non-malignant, neck dissection is not done, depth of invasion is 1 millimeter, 2 millimeter. So just you can avoid unnecessary surgery. You can keep these patients in follow-up. But if upfront, if you have a diagnosis, then it is better to do neck dissection because we don't know whether it is going to be 1 millimeter, 2 millimeter, and 3 millimeter.
Harish, you can stick to your neck dissection part in the exam, and there will be no harm. You can say that I will do neck dissection in all the cases. That's it. So
Yes.
And the other thing you have told us about the indication of segmental mandibulectomy. You have not mentioned in the recurrent post-RT cases. In those cases, you should do a segmental always. Don't do the marginal. Because time is less, we are not going into detail of that. Then you have told us about the marginal mandibulectomy, that most of the time you do a horizontal then the vertical, but in the tongue is the one place where because the invasion of it's the biological thing, it's the how the tumor invade the mandible. So in the tongue and also in the buccal mucosa, that the tumor invade from the abutment side. So the abutment side is a little bit lower in the tongue side than the buccal mucosa side. So you have to do a vertical or oblique partial marginal mandibulectomy whenever you have to do in the tongue cases if it is in the tumor is going into the floor of mouth.
Dr. Saurabh, I think I would like to interrupt you here. It's
Yeah,
a
yeah,
very
sure.
interesting discussion which is going on,
Yeah, yeah, yes.
but the time is up. So would request for a last comment from Dr. Kapil sir, and then we close this session on surgery.
Dr. Harish has presented very well, and the comments from Dr. Shilpi and Saurav have been very, very commendable. And the role of surgery in cancer tongue is very, very important. And the type of surgeries to be done, type of neck dissections to be done, and type of reconstruction needs to be done, and the various papers which Dr. Harish has mentioned, they are very, very lucid, and I congratulate him for presenting very well. Thank you very much, and thank the organizers for calling us for this meeting. Thank you.
Okay. Thank you all the mentors, and thank you, Dr.
Thank you.
Harish.
Thank you.
With this, we now move to the session on the role of adjuvant radiation therapy in cancer tongue. And I invite Dr. Munish Kerala. Dr. Munish Kerala, sir, is a head of Department of Radiation Oncology at RGCI. Dr. Tripti Saxena, she's heading the Department of Radiation Oncology at Fortis Noida. Dr. Charu Garg, she's heading the Department of Radiation Oncology at Max Saket. So these are the mentors. And now I invite Dr. Gautam. Dr. Gautam is senior resident at Max Hospital Saket, and he'll be speaking on this subject. Dr. Gautam, kindly start.
Yes. Is my screen visible?
Yes, your screen is visible, you're audible.
Yes.
Please make it full screen. Dr. Gautam is running high-grade fever and he's agreed to still do the presentation. So
Good evening, everyone. Thank you for this opportunity. So the topic for today given to me today is role of adjuvant radiation therapy in oral tongue cancer and what a radiation oncologist must know. Starting with an introduction, lip and oral cavity cancers, as per the GloboCan 2020 statistics, account for about 10.3% of all the cancer among both sexes and 8.8% of the cancer-related deaths. And oral tongue is the most common subset of carcinoma within oral cavity. And a few studies have determined that oral tongue malignancies to be associated with higher rate of local failure, distant metastasis, and lower OS compared to other oral cavity subsets. Coming to how to interpret, as my surgical colleague discussed, oral tongue is a surgical malignancy. After the surgery is done, the patient ends up in our radiation oncology OPD. The first important thing would be is to interpret the histopathology report. This is an example of a histopathology report from our hospital. The whole histopathology report explains in detail the specimen, about the gross examination findings, then coming to the microscopy examination finding. Any oncologist must spend at least 5 to 10 minutes reading in between lines, reading all the relevant details, which would have both adjuvant implications on the adjuvant treatment and the prognostication. I would like to just go through it once. A tumor, the histological type, the tumor size, depth of invasion, the high-risk host pattern of invasion, the lymphocytic response, the angio invasion, perineural invasion, margin status being very important. The gross gives an idea. We have to imagine tongue is a three-dimensional size, N size, the DOI from the latest JCC 8th edition, margins, EC status, PNI, LVSI, worst pattern of invasion, histology, and differentiation. Based on these prognostic factors, like they form the basis for the adjuvant treatment. Coming to the basic indications for adjuvant radiation alone, and adjuvant chemoradiation. For the adjuvant chemoradiation, we have evidence from URTC 22931 and RTOG 9501, the Bernier and Cooper et al., the famous pooled analysis, which shows that for the subset with the positive margin and ECE, chemo-RT has the best outcomes, improving both overall survival as well as the disease-specific survival. Coming to indication of post-op radiation alone, the standard indications are any T3, T4 disease, N2, N3 disease. So these are the standard indication which we all know. Coming to the other subset where the T1, T2, N0 or N1, when to give adjuvant RT? That is the question we have to answer. The softer criteria, softer risk factors are margin less than 5 mm, PNI, DOI more than 5 mm, LVSI being positive, level 4 or 5 lymph nodes, and a worst pattern of invasion. Answering this question, I would like to show some standard guidelines which we which we follow. One is the NCCN. Here we can see that in sorry, I'm just opening my pencil. So for a T1, T2, N0 subset, after surgery, if there is no nodes and no adverse pathological risk factors, then you don't have to consider any adjuvant treatment. But if there is a single node positive, you will consider RT. And for an N0, in the presence of an adverse pathological feature, then we consider adjuvant treatment as per the indication. If ECE and margin are positive, then CTRT. If positive margin is there, to consider re-resection. And if other risk features are there, then consider radiation. As per NCCN, the risk factors are ENE, positive margins, closed margins, T3, T4, N2, N3 nodal disease in levels 4 and 5, perineural invasion, vascular invasion, and lymphatic invasion. Sorry, my slides are not moving. Are my slides still visible? Hello.
Yes.
Slides are visible.
Yes.
Fine.
Okay.
Yes.
Yes, thank you. Yes, coming to MD Anderson's guidelines, again, here if you see, for the subset T1, T2, N0, if there are no pathological risk features, they will go on to observation. If there are pathological risk features, then we will consider an adjuvant treatment. So T1, T2, N0, and even a single node positive, then we will consider radiation. In absence of that N0, we should look for these pathological features. As per them as well, the pathological risk features include any T1, T2 with close margins, perineural invasion, LVSI, any T3, T4 disease, multiple lymph nodes, N2, N3, lymph node with ECE, lymph node positivity in level 4 and 5. Yes. So coming from here, I'll be explaining a few important adverse risk factors in detail. Coming to margins, what is an adequate margin? To achieve an adequate margin, surgeons remove a cup of normal tissue surrounding the clinically discernible tumor. Inadequate margins commonly lead to local and regional failure with poorer outcomes despite adjuvant treatment. Positive margin, the dictum and oral cavity is always a re-excision. The most widely accepted definition is 5 mm in oral cavity, including tongue cancers. Still, this is controversial as newer evidences are suggesting, as even my surgical colleagues showed, low margins up to 2.2 mm and even higher margins up to 7 mm, claiming that they provide an improved local regional failure survival. Also controversial is in T1, T2, N0 tumors, only a close margin, meaning less than 5 mm margin alone, without any other unfavorable histologic factor, should it warrant an adjuvant therapy. We should be mindful that 25% of negative margin and 75% of positive margin patients go on to develop a local recurrence, irrespective of whether an adjuvant treatment was given or not. Uh, this paper was already discussed by my surgical colleague. So it is a retrospective study by TMH, which was published in 2020 with a total of 451 patients. What they did was they grouped their patients into 3 groups with margins less than 2 mm, with margins 3 to 7.5 mm, and margins more than 7.5 mm in the group 3. And they systematically showed that every margin increase provided a mean of 3.6 months survival advantage. And the most significant advantage which they saw was up to 15 months when we see the margins increase from 7.6 to 8.5 mm. And beyond this, there was no significant advantage. And this group, so this patients were irrespective of whether they had an adjuvant treatment or not. Among the patients whomever did not receive any adjuvant therapy, a significant better LR loco-regional failure survival was observed in group 3, meaning with no RT or RT, the group 3, meaning the margin more than 7.5 mm, had better local control. So this paper concludes to take 0 to 2 mm as a positive margin, 2.1 to 7.5 mm as a close margin, and more than 7.6 as an adequate margin. Though it is not the standard of practice, we still go by 5 mm as the cutoff. Yeah. Coming to the next important factor, which is PNI. PNI is a perineural invasion. It is important to distinguish perineural spread, tumoral spread, PNTS, from PNI, because though these terms are used interchangeably, they are different. PNI is a histological diagnosis where PNTS is a gross nerve involvement, which is seen in imaging. It is generally accepted that 33% of the nerve circumference has to be surrounded by a tumor cell to consider PNI. The usual incidence of PNI reported varies from 6% to 30%. PNI is subclassified either as an intratumoral or extratumoral, and also uni or multifocal. So it is very important from a radiation oncologist perspective that we clear this point. Only an extratumoral PNI will warrant covering PNI pathways or in the CT. So again, a study done from TMH, which shows PNI as an independent prognostic factor. So it was a retrospective study published in 2017 with 1,500 patients. In this series, 30.5% of patients had PNI, and they found an association. Higher the T stage, more the PNI. T1, T2 had 17.3%, up to them had PNI. T3, T4, 24.7 had PNI. PNI positivity went along with the nodal metastasis, poorer grade of differentiation, and tongue cancer as a specific subsite has more associated with more PNI. Addition of adjuvant RT to patients with early node negative cancer with PNI alone showed an improvement in survival, both OS and DFS. This was their conclusion, and they asked us to consider an adjuvant treatment for PNI being positive. Then coming to DOI. So as we all know, DOI has been taken into the AJCC staging, it's a clinical staging itself. So the DOI is a depth of invasion, which assesses the invasiveness of the carcinoma, regardless of the exophytic component. So it is important we know the difference from tumor thickness and DOI. So in this histological diagram, we can, so what they have done is exactly, this is an ulcerative lesion, this is a proliferative lesion. It is measured by first finding the horizon of the normal basement membrane. So we draw a perpendicular line in relation to the normal adjacent basement membrane. So that depth corresponds to the DOA. So in an exophytic tumor, the DOA would be lesser than your tumor thickness, and as we can see in this ulcerative tumor, the DOA is more than what the tumor thickness would be. And studies have shown that tumor thickness of more than 4 mm, not just the T stage, is correlated with increased risk of occult cervical metastasis as well as reduced survival. Coming to the important question, like if DOI being present, does it justify an addition of an adjuvant RT, like in the absence of other risk factors? So this is a study published in 2020. It was an international collaborative study with patients from multiple centers. The disadvantage of like the negative aspect of this trial was that they have not mentioned the exact subsites, how much the oral tongue patients were. But in these 1,400 patients, there was no association found with the various DOI. So as per them, DOI alone should not be considered as an indication for post-operative radiation outside the clinical trial. But coming to another older trial published in 2013 by Gandhi et al. In this trial, the patients were from MSKCC and Mrs. Margaret Center. So in about 164 patients of oral tongue T1, T2 with no other risk factors, this is an era like where DOI was not into the normal practice, and they have used tumor thickness as the to show their outcomes. The regional recurrence rate was 5.7% for tumors less than 4 mm and 24% for the tumor thickness more than 4 mm. And in this 24% patient subset, the ipsilateral pattern of recurrence was ipsilateral in 61% and contralateral in 40%. So we can take in this way that if the tumor thickness was more than 4 mm, up to 40% of their patient had contralateral failure. So as per them, tumor thickness more than 4 mm is a very strong risk factor for adding adjuvant treatment. And coming to other risk factors which we see in our pathology report, one is this pattern of invasion, which is usually of 5 types, of which due to the paucity of time, I'm not going into detail. So they come as five subtypes. The pattern of invasion 4 and 5 is defined as aggressive, and WPOI 5 histologically is defined as tumor dispersion of more than 1 mm between the tumor satellites. This alone is a significant risk factor which has been established in several papers. In an early stage T1, T2 oral cavity, squamous cell carcinoma with more than 4 mm DOI, a presence of WPOI5 is significantly predictive of local recurrence and disease-specific survival, and the probability of developing loco-regional recurrence is 42%. As my surgical colleague mentioned, there is a Brandwein Gansler et al. Scoring system which puts three risk factors together to give a score which will predict the pattern of failure as well as the prognostication. Several such scoring systems are there. Coming now to yes,
kindly try and conclude so that we have some time for discussion.
Yes, ma'am. So coming to post-operative radiation, the interval between the preferred interval between resection and post-operative RT is less than 6 weeks. Before initiation of radiation, patient should be ideally evaluated by a team of dental surgeons from dental prophylaxis aspect, filing of sharp tooth to be done, extraction in case of caries, impacted tooth, teeth with periodontal disease, physiotherapy team from an aspect of speech, swallowing and mouth opening exercises, nutritionist for ensuring adequate dietary intake. Coming shortly to 2D techniques. For early lateral tongue, anterior and lateral wedged fields can be used. For an extensive tumor, opposing fields to be used. For an lateral opposed field, the anterior field will be in front of the mandible to exclude the lower lip if possible. Posterior, the margin will be if node negative behind the vertebral bodies, if node positive behind the spinous process, superiorly 1.5 centimeter above the tongue, and inferiorly at the level of thyroid node. And if you are treating the whole neck, it has to be matched with an anteroposterior supraclavicular field, which the superior border will be the thyroid node, the inferior will be below the sternoclavicular joint. The lateral boundary will be either the 2/3 of the clavicle or 2 centimeter lateral to your lymphadenopathy. Coming to IMRT, as we know, IMRT increases the dose gradient between the target volumes and surrounding tissue, used to spare the contralateral parotid gland and diminish the risk of long-term xerostomia, as shown by our passport trial. The grade 4 xerostomia decreased from 83 to 29% at 2 years after treatment. The significant advantages of IMRT over the conventional is salivary gland sparing, improved GTV coverage, sparing of critical optic and auditory structures, decreased acute late side effects with improved conformality, avoidance of match chain inhomogeneities associated with proton-electron matches, as well as the simultaneous integrated boost is possible. Disadvantage, potential for marginal miss and local failure from overly restrictive radiation deposition in regions that receive comprehensive radiation. So coming to steps of CT simulation, a patient is taken supine on a flat tabletop, the head and neck immobilized in a neutral neck position with a reproducible immobilization device, with a example like a 4 to 5 point fixation thermoplastic cast mask. Mouth bite is a very institutional preference. Few centers use it, few centers don't use. Wiring of scar's lips involves skin by the primary or the nodes to be done. Bolus to be given. IV iodine contrast 1 to 2 ml body weight. CT is acquired from base of skull to the below the sternoclavicular joint. Usually the CT is acquired at 3 mm. Fusion with the pre-op images to be done. Pre-op available MRI, the FTG to get an idea about the tumor burden. So coming to our contouring the volumes. For an anterior tongue, the primary will include the tumor bed, the entire oral tongue, the base of tongue. We will be considering treating bilateral neck even for a T1, T2 well lateralized tumor. The CTV for a T1 to T4 N0 will be ipsilateral control level 1 to 4. As soon as N1, I will be considering treating levels 1 to 5. So this is a Grigor's paper as far as newer neck node classification. He has given the levels to be included in our low risk CTV volumes. So for an N0, N1, so we'll be taking 1 to 4A. This 9 is for the buccal mucosa, the buccofacial group of lymph nodes. And for the contralateral, again, it is 1 to 4A. And N2, A to B, it will be 1 to 5B. The contralateral is 1 to 4A. For N2C and N3, it is again 1 to 5A. 7B to be included in case of bulky involvement of the upper part of the level 2. 7B is the retrostyloid up to the base of skull, and the contralateral 1 to 4A to be taken. So coming to the radiation doses in a post-operative setting, so the CTV66, which is to be given for regions of soft tissue invasion, bone invasion, microscopically positive margins will be included in this margin, which is 66 gray in 30 to 33 fractions at 2 to 2.2 gray per fraction, intermediate risk CTV of 60 gray in 30 fraction at 2 gray per fraction, and the low risk CTV 54 in 30 fractions, 1.8 gray per fraction. So the 60 in absence of your ECE and your margin positive, CTV60 usually covers your primary tumor bed and the level of side of dissection. And the CTV54, the low risk will be usually your opposite neck. So these are few contouring pictures from Nancy Lee textbook. So here it is a T2N1 oral tongue post surgery. They have taken the whole tongue, and we can see the 60 gray volume going into continuing as the neck nodal volumes as well. And the other images here of advanced stage who should have had a higher level 2 node, so they are covering the retrostyloid node in these images. And we have to be careful that we cover the entire flap, the scar to be taken, and all the post-op changes to be involved in our CTV. So how much more time I have now?
You've already exceeded your
Yes,
time. I suggest that you conclude.
Okay, so coming to PNI pathways, the name, as we already the nerve supply of tongue was discussed. Like named nerve involvement in a tongue is usually uncommon. Only the small unnamed nerves are up to the 40 to 50% it is involved. When adjuvant radiation is administered, the volume should not routinely encompass the CN cranial pathways up to the base of skull, unless there is a clinical radiographic or a pathological evidence of a gross named nerve or a CN involvement. These are few pictures showing how they cover PNI pathways. There are extensive guidelines available for it. Coming to OYA, so that's it, OYA doses and toxicity. Thank you. Sorry, I exceeded the time.
So thank you, Dr. Gautam, for a detailed discussion on aspects of radiation therapy. I request the mentors to kindly start the discussion.
Gautam?
Yes, sir.
Extensive
Sorry, ma'am, your voice is breaking up. I'm sorry. I didn't.
Am I audible now?
Yes, ma'am.
Okay, I'm saying that you have done an extensive, reading into the post-op histopathology. Did you come across like what percentage of margins shrink in the post-op period? I mean, if we have surgeons also on board, and if we have a pathologist so is there any consensus on that?
I think up to some 30% of tumor shrinkage can be seen when we preserve a specimen in formalin. So we have to account for that as well. Yes.
Dr. Gautam,
Yes, sir.
you have covered very extensively, rather more, whatever we were expecting is much more you have done. Another thing is very few basic questions.
Yes,
Why
sir.
do you, what is the rationale of giving adjuvant radiation, post-operative setting in the tongue? You tell me.
Yes, sir.
Please, let us start with very basic.
Yes, sir. To prevent a local and a loco-regional recurrence, like improving local control. Yes, sir.
And what is the dicta that in which cases we should, give radiation or adjuvant treatment? Like, post-operative radiation should be given in the patient who have more than 15 to 20% chances of recurrence.
Yes.
And there are wherever there are high risk features which you have already mentioned, like P3, T3, T4, lymph nodes, any multiple lymph node. So again, my question to you is, you said that single node you will give, single positive node. Say, for example, there is a T2 and 1. Would you like to give radiation?
In the absence of all other risk factors, right? Yes, sir. Even a single node, I will be considering giving radiation.
Irrespective of the, say, for example, level 1 lymph node is involved.
Yes, sir.
So, and T2 and 1, so you will give radiation? No, the recommendation is if there is a level 4 or 5 lymph node and single node, then only we should add radiation. Otherwise, we can avoid radiation in those situations. Okay. And what about single node positivity is there in level 1 or 3? 1 and 3 level lymph node, it's not a very strong indication. It is a weak indication. Though if you see the NCCN guidelines, they say you can consider, it's a two-way, you can consider, but it's not a very strong, because it is on the basis of all the retrospective trials. So it is not a very, very strong indicator. But yes, level 4, 5, even single lymph node, we should always give radiation. And another thing I just wanted to ask you, say you said margins, if margins are close, so less than 2 or 0 to 2, we should always add, it's considered as a positive margin.
Yes.
So if the margin is having a high grade dysplasia, cut margin is high grade dysplasia, would you give radiation or not in this situation?
Yes, sir.
It should be given. It should be given. That is also indication for given if high grade dysplasia is there. Another thing is, say for example, margin is positive. and you have revised the margin clearly. There is a clear margin. In that situation, would you give radiation or not?
Yes.
What
sir.
are the recommendations?
Once margin being positive itself is considered as
It's always positive. Yes,
always,
very good.
yeah.
So we should always try to give radiation, even if the margin is clean, and we all give radiation. And the another is LVI. What is the indicate? What are the evidences for LVI? LVI and radiation, post-operative radiation. You said about PNI. Yes,
Yeah.
I agree, but I don't agree with you that we should give only in extratumoral and we should not give intratumoral, because the JP Agarwal et al., that article which was published, and that was the landmark article, they have not mentioned anything about intra or extra.
Oh.
Invariably, they gave two radiation for each and every patient, and they have shown that advantage or if PNI is there. So what do you think about LVI?
So LVI alone is not a strong, like it has to be with another risk factors, then we will be considering, or like it's a soft indicator for a like it actually shows more cervical lymph node rates, LVI being positive.
Yes, I agree, because if you see, there is no trial in which they have compared LVI versus no LVI. Like in PNI, they have a very good trial in which they have, though there are a lot of studies in every year till 2017, 4 or 5 studies are there, and on the basis of which many of them, they say that yes, if LVI is there, the chances of recurrences are in the range of again 15 to 20%, and it's a high risk. So we should try to add radiation, but again, the indication, the evidences are not very high in those situations. Another thing, you said worst pattern, WOPI. On the basis of WOPI, do we add radiation?
No, sir, not yet. But I found an article telling WPI with the DOI more than 5 mm. And usually WPI 5 means that other risk factors also would be respectively be there. In that case, to like they portend like poorer local control. So then to consider, these are all newer, like still a gray area where we don't have strong.
Yes. And then in post-operative setting, in concurrent setting, what are the indications?
So two are the strongest indicators. One is the ECE and other the margin positive, which we got from our.
Yes. Dr. Charu and Dr. Tripti, please.
Thank you, Dr. Gautam. Very nice and elaborative presentation. Like again, I would like to emphasize scanned revised margins be equated with the frozen section margins. If the margins were closed and the margins were revised, then what is your call on giving adjuvant radiation on that?
So once if it is revised, then it's a risk factor, ma'am. Like we wouldn't take that as a value. It has to be considered as a strong like a reason to.
Because surgeons are also on board, yeah. Because once the revised, there are many papers in the meta-analysis that show that revised margins cannot be equated with the like frozen section margins, and we need to give emphasis on that.
Sure.
Yeah. And the other thing is like the thing which you have not covered is brachytherapy. What are the suitable candidates for brachytherapy?
So for an adjuvant setting, it's a T1, T2, and
okay.
Actually, this was
not in adjuvant setting.
Yes,
this
so,
was
my topic became adjuvant one, so actually I removed it.
Yes.
Okay, sorry.
Yes.
Okay, sure.
Ask the surgeons, just quick the surgeons on board. And if you are doing a frozen section, the margins in that we be trending the cells and formalin, preserved in formalin. So that do your pathologist, sort of consider that.
Charu, you're not audible. Dr. Charu, you're not audible.
So may I answer here? I just want to.
Yes, Dr.
So,
yeah.
So now it is a very gray area on the margin. The frozen, yes, there are papers. If the frozen is, if it is the margin was positive and on frozen it is negative, definitely that patient has to be taken as the post-op party. Definitely, if you were in the early tongue cancer or early buccal mucosa cancer, we are because debating about the tongue cancer today. But the when margin is closed, if we say the margin is mucosal margin is 3 millimeter, 4 millimeter, and you have revised it, that and one margin is like that. It's from the surgeon prerogative. All surgeons are here. I can consider that as a negative margin in the early tongue cancer. Definitely for the deep margin, it is deep margin. It's very difficult to revise. You can't say that you are revised at the deep margin. Deep margin is almost impossible. You can confirmantly say that you have revised it and it is negative. But yes, peripheral mucosal margin, if it is a closed margin, not the positive margin, you become negative margin. But if it is a closed margin and you have revised on the frozen section on one margin, that can be taken at negative. I don't know, the other surgeons are also there. Shilpi is there, Dr. Mudis is there. They can put up their thoughts.
Hello.
Yeah.
Dr. Mudit. No, Dr. Mudit is there?
He was there. He was.
No, probably he's not there. Probably he's not there.
Shilpi is there. Shilpi. Dr. Kapil.
Okay, meanwhile, I think I would request Dr. Munish sir to kindly answer the question raised by Dr. Indu in the chat box. What about a very young patient who has no standard high-risk indications for RT, but 2 to 3 soft indicators? Would you consider radiation?
Yes, definitely. If there are 2 to 3 soft indicators are there, we should add, and we are adding. Individually. Say, for example, if any patient is having 6 millimeter depth, I would not prefer to go radiation because 6 to 8, 5 to 8 is always a gray area for me. So I don't add. But if this is associated with, say, worst pattern 5 or it's a, then in those situations, definitely we should add radiation. What I'll say, Dr. Indu, what do you do?
Definitely, I just wanted to tell that age is also to be taken into account because
Yeah.
these young patients are at very high risk, and we all know that tongue is a very notorious area for recurrence. So if there are 2, 3 soft indicators or intermediate risk factors, then we should consider radiation.
Yeah, ideally,
yes.
So I think with this, we conclude the session on radiation therapy. We had a very interesting session, but we are running late by 12 minutes. Thank you.
Oh.
Thank you, Dr. Gautam.
Thank you. Thank you all for this opportunity.
Thank you.
Thank you.
We move on to our next.
Thank you, Dr. Gautam. Yeah.
Thank you, Dr. Gautam. So we move on to the next session. The next presentation is by Dr. Akanksha. She's doing DNB in medical oncology from Narayan Hrudayalaya Dharamshila Hospital. She will be speaking on the role of systemic therapy in oral cancer. And I invite her mentors also, Dr. Sohail Qureshi, Dr. Rajat Saha, and Dr. Priya Tiwari. Over to you, Akanksha. Akanksha, you're not audible.
Am I audible now? Am I audible now?
Yeah, go ahead.
A very good evening. At the outset, I would like to thank the organizers for giving me this opportunity. And I would like to thank my mentors for helping me prepare this presentation. The topic given to me is systemic therapy in head and neck cancer. Before I start on with my presentation, I would like to emphasize that the new era of treatment paradigm in head and neck cancer consists not only of chemotherapy, but of targeted therapy, including the EGFR inhibitor cetuximab, and immunotherapy, including PD-1 inhibitors pembrolizumab and nivolumab. A brief history. Before 1970, the initial treatment of the patients with locally advanced stage 3 and non-metastatic stage 4 was surgery with or without radiation therapy. But due to the dismal results obtained with this therapy, systemic therapy came into picture. In 1980, the combination of cisplatin and continuous infusion 5-FU was introduced for these kind of patients. And at the same time, the concept of concurrent chemotherapy came into being for patients with inoperable or unresectable head and neck cancers. And it was seen that with the addition of chemotherapy, there was provision of better local control, lower incidence of systemic recurrences, improved disease-free survival, and most importantly, improved overall survival. So from then on, the addition of chemotherapy was explored. At the present day, the indications of chemotherapy in the curative setting includes the form of induction chemotherapy, concomitant chemotherapy, and adjuvant chemotherapy. And chemotherapy can also be used in the recurrent or metastatic setting. The factors affecting the treatment choice are the performance status and comorbidities of the patient, prior treatment taken by the patient, and the time since the last treatment, the pathological features including margins, ENE, and PD-L1 status, the patient preference, and the logistics. Coming on to induction chemotherapy as part of organ preservation. So induction chemotherapy can either be used as part of organ preservation or in the unresectable cases. As part of organ preservation, in patients with resectable disease, induction therapy followed by RT-based approach was investigated. It was conducted in laryngeal, hypopharyngeal, and base of tongue tumors. Why these tumors were chosen? Because surgical resection in these tumors led to substantial morbidity. 2 sentinel phase 3 randomized trials were done. One was by the Department of Veterans Affairs Laryngeal Cancer Study, and other was by EORTC. Coming on to the VA trial. In VA trial, the patients were randomized into 2 arms. The surgery, that is the laryngectomy followed by RT, or 3 cycles of PF-based induction chemotherapy followed by RT. The most important finding was that 2-year survival was similar in both the arms, but in this arm where induction chemotherapy followed by RT was used, 64% laryngectomy-free survival was seen with the induction therapy. Also, with the EORTC study, which was done in hypopharyngeal cancer, again the same arms were compared, surgery followed by RT or induction chemo followed by RT. The treatment failure at the local, regional, and second primary sites were similar. Median survival was similar, but in the arm where induction chemotherapy was used, distant failure rates were less. And 5-year estimate of preserved laryngeal function was in 35% of the patients. So these both trials, they solidified the use of induction chemotherapy followed by radiation in resectable patients as the standard of care. Coming on to induction chemotherapy for unresectable disease, these 2 studies by Pecnella et al. And Domenji et al., they used 3 to 4 cycles of PF-based induction chemotherapy followed by CTRT, and it was seen that in the study by Domenji et al., overall survival benefit was there. And then it was also seen that with the addition of taxanes, the response rate rose to 34 to 40% in head and neck squamous cell carcinoma. So they thought, why not try adding taxanes with this PF-based chemotherapy? That is why TAX 323 and 324 came into picture. These both trials, they compared the triplet induction, that is TPF-based chemo or PF-based chemo followed by RT. And the results were better with the TPF-based chemotherapy in terms of PFS as well as overall survival with the significant p-value in both the arms. Similar were the results with TAX 324, where TPF-based therapy did better than the PF-based induction chemotherapy. So this established that TPF-based induction chemo is better than PF-based chemo. But as of now, we know that there are 2 trials, DECIDE and PARADIGM trial, which shows that the role of induction chemotherapy in head and neck is very limited. Coming on to adjuvant chemotherapy, we all know about these 2 trials, one by EORTC Bernier et al. And other is RTOG 9501 by Cooper et al. These both trials, they took high-risk features. The high-risk features in EORTC trial was margin positive, ENE positive, LVI, PNI, and level 4 or 5 lymph nodes. And in RTOG trial, the high-risk features were margin positive, ENE positive, or 2 or more lymph node positive. These both trials, they compared the adjuvant CTRT with only radiation therapy. The chemotherapy used here was cisplatin at a dose of 100 milligram per meter square 3 weekly. It was seen that there was in URTC trial, there was better DFS and better 5-year overall survival with the use of CTRT as compared to RT alone. Also in RTOG trial, there was better local regional control and better DFS with significant p-value. Though 5-year overall survival was not significantly better, but numerically it was also better as compared to only RT. But when the joint retrospective analysis was performed by these two authors, it was seen that only these two features, that is ENE positive and margin positive, only these two pathological factors were most strongly associated with the better DFS and OS. So these trials established that concurrent cisplatin at a dose of 100 milligram per meter square 3 weekly with radiation therapy is the standard of care with these two features, that is either ENE positive and or surgical margin positive in the adjuvant setting. Coming on to locally advanced unresectable cancers, this trial by Edelstein et al. Published in JCO in 2003, it had 3 arms divided 295 patients. Arm A received only radiation therapy, Arm B received cisplatin along with radiation therapy, and Arm C received split course radiation therapy along with the cisplatin. And it was seen that Arm B, that is the concomitant cisplatin along with radiation arm, though it had more toxicity, but the overall survival was only better in this arm, that is 37% with a significant p-value as compared to only 23 and 27% in other 2 arms. So this established the addition of concurrent high-dose single-agent cisplatin to conventional single daily fractionated radiation therapy. It improves survival in this subset of patients.
I will be giving, would be continuing with the.
At the same time, we know that with the rationale that EGFR is overexpressed in 92% of the head and neck squamous cell carcinoma patients. With this rationale, Bonner et al., he tried the EGFR inhibitor, that is cetuximab, in the therapy. These 2 arms were randomized. One received only radiation therapy and other received radiation therapy along with cetuximab. And it was seen that with the addition of cetuximab, the median overall survival, the 5-year median survival was better in the combination arm. That is 45% as compared to 36% in the radiation alone arm with a significant p-value. Also, the local regional control was better in the combination arm with a significant p-value. The only toxicity which was increased in the cetuximab arm was skin reaction and mucositis. So this trial established that cetuximab is a valid option in cisplatin ineligible patients along with the radiation therapy. Coming on to the ESCORT-N study, which established the role of nimotuzumab, though it was done only in 29 patients, randomized patient into 2 arms. One received only CTRT and other received CTRT with nimotuzumab. And it was seen that though it was not statistically significant, but the patients who received nimotuzumab had better survival outcome as compared to only CTRT arm. Now, this is the McKinsey, the updated analysis published in Green Journal in March 2021. It established the role of concurrent chemotherapy in non-metastatic carcinoma. It compared the curative locoregional treatment with chemotherapy, and it also searched for the timing of chemotherapy, whether it should be concomitant or it should be induction or it should be in the adjuvant settings. It took into account 101 trials and 19,000 patients were analyzed. And it was seen that the benefit of chemotherapy was limited to the concomitant setting. Overall survival was not increased by either induction or adjuvant. It was only increased with the addition of concomitant chemotherapy. The 5-year absolute benefit was 6.5% and 10-year absolute benefit was 3.6%. Also, the efficacy decreased with the age. That is, in more than 70 years of age, there is no benefit of adding chemotherapy. So the update of McKinsey confirmed the superiority of concomitant CT in overall survival for non-metastatic head and neck cancer patients. Now, these all trials, they established 100 milligram per meter square 3 weekly as the cisplatin as the standard of care. But most of the clinicians, they use 30 milligram or 40 milligram per meter square weekly as the standard dose. This is based on these two trials. One is JCOG 1008 and other is the consort trial. These both trials, they compared cisplatin 100 milligram per meter square 3 weekly to 40 milligram per meter square weekly with concurrent radiation as definitive therapy. Primary objective was 2-year locoregional control and secondary endpoints were overall survival and progression-free survival. And these trials, they confirmed that CTRT with weekly cisplatin is non-inferior to 3 weekly cisplatin, and weekly cisplatin is better tolerated with less interruptions, with less hospitalizations, and with less toxicity as compared to 3 weekly cisplatin, and can be considered as the standard of care. Coming on to chemotherapy in the metastatic setting. Starting with the extreme trial published by Vermoken et al., they took all the metastatic patients and they randomized the patients into 2 arms. One arm received PF-based chemo, that is platinum, either cisplatin or carboplatin, along with 5-FU for total of 6 cycles. And the other arm received the PF-based chemo with the addition of cetuximab to a dose of 400 milligram per meter square, the loading dose, followed by 250 milligram per meter square weekly until the disease progression. And it was seen that with the addition of cetuximab, the median overall survival was much better. There was 2.7 months benefit with the addition of cetuximab as compared to only PF-based chemotherapy. So this trial established cetuximab along with PF-based therapy as first-line treatment in the metastatic setting. Then came the TP extreme regimen, where instead of 5-FU, 5-FU was replaced by docetaxel at the dose of 75 milligram per meter square IV. And instead of 6 cycles in the extreme arm, they gave 4 cycles in the TP arm. TP means taxane as well as the cisplatin combination along with the cetuximab, followed by cetuximab maintenance. The primary objective was overall survival and secondary was quality of life. And it was seen that although overall survival was not better with TPX arm, but the toxicity was much less with the TP-based chemotherapy. Coming on to Keynote 048 trial, this is the most talked about trial in the present era. Here, all the metastatic patients of all the subsites were included, the squamous cell carcinoma of head and neck patients. They were divided into 3 arms. One arm received only pembrolizumab at a dose of 200 milligram 3 weekly for a total of 35 cycles. The other arm received pembrolizumab along with the PF-based chemotherapy, followed by the pembrolizumab maintenance. And the third arm was extreme, which we have already discussed. Now this trial, it compared the cetuximab arm along with the pembrolizumab arm. And it was seen that as compared to extreme arm, when pembrolizumab plus chemotherapy was given, there was better median overall survival. It was 13 versus 10.7 months with a significant p-value and better hazard ratio in the pembrolizumab plus chemotherapy arm. So it established that as compared to extreme arm, pembrolizumab plus chemotherapy, it do much better. And if we talk about pembrolizumab alone as compared to extreme, again, it was seen that pembrolizumab alone is better as compared to extreme arm. The median overall survival was 15 versus 10 months with a significant p-value, and in CPS 1 also and in CPS 20 also. In both these, the pembrolizumab alone was better as compared to extreme. But this benefit was seen, you can see initially these curves, they are hugging each other. After about 8 months, these curves, they start separating and the duration of response with pembrolizumab is maintained after that. It shows that CPS either more than 20 or CPS either more than 1, pembrolizumab does better as compared to the cetuximab arm. And this shows the PFS. Although the overall PFS was not better in the pembrolizumab arm, but if we look at the PFS at 12 months and at 24 months, the pembrolizumab arm does better. But the overall survival was definitely better in the pembrolizumab arm as compared to the extreme. So this established that pembrolizumab can be given in the first-line setting in the metastatic setting. Coming on to Checkmate 141, which used the nivolumab. Now this was in the platinum refractory setting. That is after the platinum therapy. Now they were randomized into 2:1 arm. One arm received nivolumab at the dose of 3 mg per kg, and the other arm received the investigator's choice of chemotherapy, which may either be methotrexate or docetaxel or cetuximab. The primary endpoint was overall survival, and the other endpoints were PFS and overall response rate. Mind you, this is the platinum refractory setting. And it was seen that nivolumab did better as compared to the other chemotherapy. The median overall survival was 7.7 as compared to 5.1 months with a significant p-value. It established that nivolumab can be given in the platinum refractory setting as the standard of choice. Similarly, this pembrolizumab in the Keynote 040 trial, again the same standard of care was compared with the pembrolizumab arm 200 milligram 3 weekly. Again, it was the platinum refractory setting, and it was seen that again pembrolizumab did better as compared to the standard of choice of chemotherapy. The median overall survival was 8.4 versus 6.9 months, favoring the pembrolizumab arm with a significant p-value. This also established that pembrolizumab can be given in the subsequent line of chemotherapy. And the subset analysis was done in CPS more than 1 and CPS more than 50. We can see that in CPS more than 1, initially these curves, they hug each other and then they gradually separate. But still the median overall survival was better in the pembrolizumab arm. And in CPS more than 50, they start separating right from the beginning, telling that pembrolizumab did better in, it did far better in CPS more than 50 as compared to CPS more than 1. Now coming on to this low cost, low dose metronomic therapy, this was published in Lancet 2020. This was done in Tata Memorial Hospital. Now this trial was done because in the low and middle income countries like ours, like India, where the cost is an issue, and also the health status or performance status of the patient is an issue. So this trial was done to establish the role of oral metronomic chemotherapy. In this trial, 422 patients were randomized into 1:1 arm. One arm received the oral metronomic chemotherapy consisting of methotrexate at a dose of 15 milligram per meter square with celecoxib 200 milligram BD till disease progression. Vis-a-vis, it was compared to cisplatin 75 milligram per meter square every 3 weekly for 6 cycles. And it was seen that the metronomic chemotherapy had median overall survival of 7.5 months as compared to 6.1 months in the cisplatin arm, favoring the oral metronomic chemotherapy, establishing that oral metronomic chemotherapy is non-inferior to intravenous cisplatin with respect to overall survival in the palliative setting. Now, inspired by this, this is the most recent trial published by Patel et al. In 2022 with the low-dose immunotherapy. This was also done in the Tata Memorial Hospital. Here, the patients were divided into 1:1 arm, and the palliative chemotherapy consisted of the oral metronomic chemotherapy with the methotrexate, erlotinib 150 milligram OD, and celecoxib 200 milligram BD. And this was compared with the same chemotherapy plus the addition of very low dose immunotherapy. We can see that the dose of immunotherapy is very low here. Nivolumab only to a dose of 20 milligram. The primary endpoint was overall survival and secondary endpoint was progression-free survival.
Dr.
Again,
Akanksha, time is up. Try and conclude.
Ma'am, just 2 slides. Again, it was seen that low dose immunotherapy did much better as compared to only metronomic chemotherapy in terms of both overall survival and as in case of progression-free survival. So this established that low dose nivolumab or immunotherapy plus metronomic chemotherapy can be given in such subset of patients. Even the NCCN guidelines also say that primary systemic therapy, high dose cisplatin is the category 1 recommendation, but weekly cisplatin at a dose of 40 milligram per meter square is also the standard of care. If we go for induction chemotherapy, TPF based induction to be chosen. And if we go for CTRT, again, cisplatin is the category 1. If we talk about metastatic setting, in CPS more than 1, pembrolizumab alone can be given. And if we don't have the CPS value, then pembrolizumab along with PF-based chemotherapy is the category 1 recommendation. And in subsequent line, both nivolumab and pembrolizumab are approved. My take-home points are, systemic chemotherapy in the head and neck consists of chemotherapy, targeted therapy, and the immunotherapy. Induction therapy can be used as a part of organ preservation or in the unresectable cases. Adjuvant chemotherapy benefits in margin positive and ENE positive cases. CTRT holds the maximum benefit in non-metastatic cases. Weekly cisplatin is non-inferior to high-dose cisplatin. Pembrolizumab is now FDA approved as a first-line treatment in recurrent or metastatic setting in CPS 1 as monotherapy and in other with the combination of platinum and 5-FU as frontline therapy for all patients. Both nivolumab and pembrolizumab are FDA approved in platinum refractory settings. Thank you.
Thank you, Dr. Akanksha, for a very crisp presentation and finishing well in time. Request mentors to please start the discussion.
Good evening. I'm Dr. Sohail here. Can everyone hear me?
Yes.
Okay, so thank you, Akanksha. That was a very lucid and comprehensive analysis that you've put forward. Just to start the discussion by taking up the first point about the metronomic therapy, which is now in vogue and has been presented at various forums by Tata. So just a few critical analysis. So around half of the patients in that study in the oral metronomic arm, as well as in the IV cisplatin arm, they had already progressed on platinum-based chemo within the 6 months. And we know for sure that relapse within 6 months is a marker of cisplatin resistance in clinical practice. And I don't think any medical oncologist would prescribe a single agent cisplatin for a patient who has already relapsed within 6 months of receiving cisplatin as a part of definitive therapy. Even Keynote 048 and extreme trials had excluded these patients. So basically, one could argue that the oral metronomic arm was basically compared with a weak comparator arm, which is cisplatin, and that would have possibly resulted in the metronomic therapy performing well. Nevertheless, this becomes a very important option for patients in low and middle income countries. Most oncologists in low and medium income countries will obviously prescribe doublet chemo for fit patients, considering better response rates, and therefore single agent cisplatin has inferior response rates to doublet. While at that, we must also keep in mind that doublet chemo, whether it is platinum plus 5-FU or a platinum plus taxane, they increase the objective response rates compared with single agent chemo, although no OS benefit has yet been demonstrated. So we have to be very careful when we choose the chemotherapy, and the fitness of the patient has to be kept in mind. Because if we go back to the results of TP Extreme, which mainly set the place for taxanes coming to head and neck, there was hardly any difference between the OS between the extreme arm or the TP Extreme arm. It was barely 1 month, but the taxanes got their place in the guidelines because of a shorter time on chemo and significantly lower toxicity than the extreme. While on toxicity, let me also say that yes, 3-drug and 4-drug regimes have been tested in trials for head and neck carcinoma, but the toxicity has been immense, even though higher response rates have been achieved, but they have not translated into a better survival for patients. Dr. Priya and Dr. Rajat, sir, would you like to take it forward?
Yeah, good presentation, Dr. Akansha. And Dr. Sohail has highlighted on the metronomic chemotherapy. I am trying to kind of analyze the upcoming role of immunotherapy in head and neck cancers. We are all seeing that it is definitely promising, but there are certain cases where we have certain hyper progression also with immunotherapy. So that is one side effect of the immunotherapy which we have to counsel to our patients, and it is quite prominent in the head and neck cancer subset of patients. And again, a lot of our patients of head and neck who are recurrent, they have a lot of functional impairment, and like in breast, we say it is a visceral crisis or a visceral disease. In head and neck, we have a lot of functional disability. So in those patients, we need a faster response. So chemotherapy in this case definitely gives a faster response. Plus minus cetuximab can also give a faster response. Immunotherapy, yes, in a CPS score more than 20 definitely is a very good drug to explore. And even though, and as regards a word on NSCT in this oral tongue cancers, even though definitely none of the trials have shown any survival advantage with the new adjuvant chemotherapy, but still we are quite commonly using neoadjuvant chemotherapy in borderline resectable or inoperable tongue cancers. And definitely the role of neoadjuvant chemotherapy is in downsizing the tumor and in enabling the surgeon to have a more complete surgery. Even though it doesn't translate to an overall survival, but still it is quite frequently used, and we definitely should use it also.
So I think very nice points highlighted by Dr. Rajat and Dr. Suhail. Just two or three just important part as a because we are all learning, and I think for the DNB students and for the other trainees, it's very important whenever we are doing a PowerPoint presentations, few basics needs to be kept in mind. Because these are some things which will stay with us for the rest of our lives. So please put what we call references in the slides and the studies. It's very important that you put references in a proper format, okay? That way we'll all ensure that yes, how old is the publication, how fresh is the publication, are you just presenting an abstract or are you presenting a study, okay? So these things matter. For a good presentation and a good quality presentation, the references are very important, how you are putting it, okay? That is very important. Also, a few things that you can do to further improve your presentations, and that is for all the DNB students is that you should, if you understand something, like you're talking about the metastatic disease, okay? We ran through certain slides, we find out there's a role of cetuximab, there are role of different type of chemotherapies, we have immunotherapies. But if you're sitting in an OPD tomorrow, then how are you going to take this this presentation and put it in your practice? So maybe if you can put in a flow chart. So if the metastatic cancer or a recurrent cancer comes into your setting, so what should be the flow for your treatment that you will decide, what factors that you are going to decide. So if you put a flow chart, maybe you'll see the platinum-free interval, whether it's a first-time disease or a recurrent disease. And you will have to see whether you would like to do a PDL1 upfront in all the cases or not. So maybe a flow chart would help you to decide in your clinical practice and for the rest of also that the presentation that you have read and the slides that you have made, how are you going to apply that into your clinical practice? So whenever you make a presentation, always try to put a flow chart so that helps you to improve your understanding and that you can of course apply to your clinical practice. Most of the points were beautifully highlighted regarding the role of cisplatinum, carboplatinum. The role of cetuximab has actually become quite controversial, especially after the study where it has actually shown, it was a retrospective analysis, but a wonderful analysis of carboplatinum versus cetuximab, where actually carboplatinum has improved overall survival figures compared to cetuximab. So we now have data for carboplatinum also being better than cetuximab. So that's also put a cetuximab at a very difficult position. But yes, metronomic therapies, immunotherapies, targeted therapies have also have all come into role in head and neck cancers where the ground was quite barren. You should also touch upon maybe next generation sequencing and like just a slide on what are the latest, because that is where the world is moving. The next generation sequencing and the other targeted therapies, what are the common mutations that we see? I did not see the first part, maybe I just missed on the 10 minutes if it was discussed, I don't know. But that is something that we should also be bringing in whenever we are discussing the metastatic part, metastatic cancers. So I think that will be all from my side.
Okay,
just a couple of points. Just a couple of points that I'd like to. Just a couple of points while Dr. Priya was talking about cetuximab, it just struck me that we know that cetuximab, when it was first published in 2008 in the extreme trial, it increased the OS compared to chemo alone. But it is important to remember that this trial did not allow crossover. So we really can't say whether the sequential chemotherapy followed by cetuximab at the time of failure would perhaps be equivalent in survival with the 3-drug combo regimen given upfront. So if you were to give chemo and then add cetuximab later on at the time of failure, would that be the same as perhaps giving cetuximab upfront? So the trial did not allow crossover. So we really don't know the answer to that question. Another question to which we do not know the answer of is that pembrolizumab, as per Keynote 048, which has been approved as in first-line metastatic setting in head and neck cancer, was studied with cisplatin and 5-FU. Now, I don't think many of us are actually using infusional 5-FU for 4 days as per that regime. And to my knowledge, to this date, there isn't a study to advocate the use of immunotherapy along with the taxane platinum combination. Although many of us are using pembrolizumab along with taxane platinum combination based on extrapolation of the TP extreme data. But to this date, there is no, in fact, even the NCCN guidelines approve pembrolizumab in the first line setting along with cis and 5-FU. Having said that, a question is often raised in various clinical meetings. What is the role of capecitabine? Now, capecitabine is a molecule that has variously replaced 5-FU in different cancers. So is there a role where capecitabine can replace the 4 days continuous 5-FU infusion? So we really don't know the answer to that. So these are 2 or 3 open-ended questions which always would arouse curiosity amongst medical oncologists.
And I think, Dr. Sohail, it is important to remember these points, especially because in the exams, they have to answer based on the available evidence.
Absolutely, ma'am. Absolutely.
So there are a few questions in the chat box. If some of you could take it up. Dr. Priya, Dr. Rajat.
So Dr. Indu has asked, should we use NSCT for locally advanced oral cavity cancers as they show distant metastasis quite early? You mean to say that? I don't think so that the locally advanced oral cancers per se are a means biologically difficult subgroup. So neoadjuvant chemotherapy will not lead to in fact, it will lead to lesser chances of distant metastasis, not increased chances of distant metastasis.
No, no. I think she wants to ask because there might be micrometastasis from day one. So
PET-CT, we see that patients come up with distant mets, especially bone metastasis very soon, say in 3 months period or 6 months period. So just a point, just a food for thought that should specifically for oral cancers, should we give, I mean, because I've seen distant metastasis occurring very early in spite of doing a PET scan and everything. So just a thought, although I'm not a very proponent of NACT, I'm just asking this question.
So that's a good thought. Maybe it was always a subset analysis, and that is why we don't have large data for just oral cavity per se. Maybe Indians can do because we have so many oral cancers. Yes, Dr. Rajat, you were going to say something.
I actually caught the question wrong way.
Yes.
मुझे लगा कि you are asking whether the neoadjuvant chemotherapy is leading to more distant. No. So definitely in the NACT subset, the number of distant metastasis is less in according to the various trials. Definitely doesn't translate over. Yes, definitely we can use neoadjuvant chemotherapy to reduce the chance of distant, and that is the logic where the 100 milligram per meter square cisplatin scores over the 35 milligram per meter square cisplatin, because the higher magnitude of chemotherapy which is given, that improves somewhere that gives the survival benefit. So
Caveat while using the NACTs, ma'am, 50% of the patient won't respond. Now, for other side, for breast cancer, the figure is not 30%. For head and neck, it is more than 30% actually. So suppose if you start NACT and the oral cavity cancer progresses, maybe you lose the patient with that person which you can treat with curative intent.
May I, Dr. Rajat?
Yes, Dr.
Yes, sir.
So Dr. Saurabh surgeon has not left. So I'm there. And I think there is no data at present to say that we should give in a locally advanced lung cancer if they are operable to start the NACT. I think that will be a wrong message to the PGs here.
The initial decision making is always in the surgeon's court. The initial decision making is always in the surgeon's court.
So if it is operable, and then it should operate. And also one more thing, that NACT doesn't work very well. What we have seen in many patients, we have done almost 50, more than 50 now, I think, Dr. Rajat, with NACT.
Yes.
So, but that doesn't do very well in the neck metastasis part. So if the nodes are there, they don't do very well in that.
So I agree that NACT in head and neck cancers is still work in progress, and much needs to be really elaborated before it becomes the standard of care. But maybe if one were to ask me, then something like high nodal positivity, big bulky nodes in the neck, or a very extensive primary, which makes the resection, complete resection, very difficult, or perhaps the radiation field to be too large, I would perhaps be inclined to give neoadjuvant chemotherapy and maybe see how it works from there. But as of till the time that we don't have any defined criteria, I think it just remains a work in progress.
Yeah, we give NACT. I think we have more than 50 cases are there. It's not like that we don't give it, but we have seen that it doesn't work very well for the nodal disease. It works very well for the primary site if it is very locally advanced tumor in the primary site, and you think that the margin can be positive on the resection. In those cases, it works very well, but not in the nodal disease.
So thank you everyone for a very, very interesting session on the role of systemic therapy. And the message is very clear that NACT is not to be routinely used in nodal cancers. If they are resectable, they have to be resected first. I think with this, we close the session on the systemic therapy. And now we start with our case-based panel discussion. Dr. Vibhay Parikh was supposed to be moderating this session, but he's got caught up somewhere. So last minute, Dr. Kanika Sood has agreed to moderate the session. May I also invite, other than Dr. Kanika, the experts of this session, Dr. Manish Kaur, Dr. Sushant Mittal, and Dr. Indu Bansal to stay as experts, while Kanika can invite her panelists. Please go ahead, Kanika.
Yeah, am I audible?
Yes, you're audible.
I just need to share my slides. I will just share the screen. So I have a disclosure. These slides are being compiled by Vibhay. He was supposed to attend it and he was all keen to present this. And unfortunately, he had to walk in early for a clinic today. So I'll be covering him for him. So ma'am has already introduced the experts. We have a budding group of panelists, which have two medical oncologists, two radiation oncologists and a surgical oncologist. Dr. Shefali, Dr. Garima are the radiation oncologists, Dr. Vikas Maheshwari is the surgical oncologist, Dr. Pooja and Dr. Grishma are medical oncologists. And we have an esteemed expert panel by Dr. Sushant Mittal from Max Shalimar Bagh, Dr. Manish Kaur from AIMS, he's a surgical oncologist, Dr. Indu Bansal, radiation oncologist from NH Gurugram. So I request the panelists to please be free to ask questions during the panel, because it will not be a summing up session since it's a case-based discussion. So please be free to ask questions in between so that we can finish up that particular discussion along with the panelists as and when the slides are posed. So I will not take much time now. I'm just starting off the case.
Kanika, make it full screen.
Yes, it is now. Yeah. So this is a 69-year-old gentleman, and he comes in with a history of irregularity over the right tongue border with some discoloration of 4 weeks duration. He doesn't give any history of pain. He's a non-smoker. He had been an alcohol user, which he has quit 10 years back. The past medical history also tells that he has sustained a medical myocardial infarction, and his current left ventricle ejection fraction is around 50%, and also is taking medications for dyslipidemia and has been taken up for a pacemaker insertion 4 years back. So first question would be to our surgeon, Dr. Vikas, if you can look at the lesion and just describe what you can appreciate in this particular picture.
First of all, thank you, Dr. Kanika, for inviting me. Am I audible?
Yes, of course. Please go ahead.
So this is a lesion. I can see it's a irregular 1 by 1 centimeter sized ulcer with everted edges on the right lateral border of the tongue, with I can see 2 or 2.5 centimeter distance from the lower gingival floor of the mouth, and from 5 to 6 centimeter from the anterior tonsillar, right anterior tonsillar pillar, and with a coated tongue.
Okay, so you beautifully described the lesion, but I believe from the examination point of view, the examiner would also want to hear a few more terms which would talk about the mouth opening as well as the mobility of the tongue, which of course you cannot make out from this picture. So this is the description which has been given to us, that there's a superficial lesion in the right lateral border of the tongue around 1.1 1.5 into 1.5 centimeters, somewhere midway in the lateral tongue. So as per the provided information, there is no limitation of the tongue movement as well. And there is no cervical lymphadenopathy. So next set of questions for Dr. Shefali I can pose is, if you see such a lesion, what would be the differential diagnosis you could offer to this particular patient?
Okay, so based on this history and examination, the various differentials that I can make are the lesion, it could be a pre-malignant lesion of the oral cavity, such as a leukoerythroplakia, or it could be a benign lesion owing to a sharp tooth or the implants that are present, and again, the differential of the malignancy.
Okay, so could you give us any points in favor of what would be your topmost diagnosis amongst the differentials which you have offered?
Okay, so based on the history and the examination, because it's a non-healing ulcer, and there has been a recent change in the presentation of this ulcer. So my first differential would definitely be a squamous cell carcinoma or malignancy of the tongue. And apart from that, based on the history of the patient does not have a chronic history of tobacco chewing, and he's also a reformed alcoholic. So the predisposing criteria for the pre-malignant lesions, they are definitely lesser. But as based on this image, I can see a lot of dental procedures that have happened. So that definitely because of a chronic irritation, a benign or a malignant cause of the ulcer would be one of my preferential EDs.
Okay, so Dr. Garima, could you just elaborate on what all pre-malignant conditions you could encounter in the oral cavity, and what is their propensity of developing cancer?
Yes, ma'am. Ma'am, leukoplakia, erythroplakia, oral submucosis fibrosis, these are the pre-malignant conditions in which leukoplakia accounts for 5 to 15% of predisposing factor for carcinoma lung. Erythroplakia standing for 30% of the cases, and submucous fibrosis also causes 10%, around 10%, 5 to 10% of predisposing factor for carcinoma tongue.
Any question from the expert panel? Would the expert panel want to ask anything more from our panelists? So there's no question. Yes.
In 2000, one thing just I want to highlight here is in 2005, WHO workshop has declared different terminology of potentially malignant oral disorders instead of precancerous. This include potential precancerous lesions as well as the precancerous conditions.
Okay, please elaborate on them. It will be a learning for your fellows as well.
So in spite of using this terminology, WHO in 2005, because of so much controversies and different terminology in different parts of the world, they put one single name of potentially malignant oral disorders, in which precancerous lesions, they included this erythroplakia, erythroleukoplakia, lichen planus, actinic chalicis. And in precancerous condition, they use any kind of chronic irritation by betel nuts or any other condition they included in that.
Okay, so we move forward.
Actually, based on this classification, the WHO 2005 classification, so basic categorization is termed as the OPMDs, or the oral pre-malignant diseases, and they are further categorized as either lesions or conditions. The lesion one being the local lesions such as the lichen planus or the leukoplakia, erythroplakia, submucous fibrosis, and the conditions are basically systemic conditions which predispose the person to malignancies.
So great. I think that compiles the pre-malignant conditions in totality. So since you are already taking the question, so the next question I would be posing to you would be that if we have a biopsy proof that this particular lesion which you saw is a well-differentiated squamous cell carcinoma, what would you estimate the risk that this patient would have of lymph node metastasis as well?
So the risk of cervical lymphadenopathy in a T1 disease is approximately in the range of around 15 to 20%. So that will be my estimate for this patient.
So I think you can very well see in the tabulated form that the risk of lymph node metastasis, even in the clinically node negative disease, might turn out to be positive on pathology in 33% cases. And the highest incidence is in the level 2, followed by the other levels. So Dr. Garima, what would be the anatomical confines of oral cavity? Can you just define the anatomical borders of oral cavity? What are the subsides?
Yes, ma'am. The subsides are the lips, the anterior oral tongue, and upper and lower gingivo-buccal sulcus, and retromolar trigon, and floor of mouth. And the extent of the anatomical border is anteriorly the vestibule of the lip, and posteriorly the junction of soft palate and the hard palate, or we can take circumvallate papilla as the posterior extent for the oral cavity.
So if you are to talk of the nerve supply of the tongue, since we have been talking of PNI and we have been talking about the vasculature of the tongue, which was beautifully described by Dr. Harish. So what is the sensory and motor supply, and what significance would you attribute to these neural involvements in these cases? Dr. Garima, can you talk about the neural supply of the tongue? Dr. Garima, are you there?
Yes,
Dr.
ma'am.
Vikas?
Yes, ma'am. I was unable to unmute myself.
Right, tell me. Yeah.
Ma'am, the motor supply is by hypoglossal nerve, and the sensory supply is by the third branch of the trigeminal nerve, that is the lingual nerve. And anterior 2/3 of the tongue is supplied by chorda tympani, which is a branch of facial nerve, and the posterior 1/3 of the tongue is supplied by the glossopharyngeal nerve, the cranial nerve.
So what would be the clinical significance in a patient? How would you see the manifestation of involvement of any of these? Dr. Vikas?
Yes. So if suppose a patient is having a deep-seated pain in ear, so in the that is a referred otalgia in the posterior 1/3 of tongue, and in the anterior 2/3 of tongue, if nerves involvement are there. So because of a common Gazarian ganglion through auriculotemporal nerve, he can have referred otalgia in the anterior aspect of external auditory canal.
Okay. Any questions from the expert panel? Dr. Indu, Dr. Mittal?
Kanika, Dr. Sushant Mittal has not joined. Dr. Manish Gaur, surgical oncologist, is there.
Yeah, Dr. Manish, would you want to ask the panel any questions till this point of time?
Ma'am, we can talk about OMPD. Sorry, I was not able to unmute myself. I had some net issues.
Right. Please go ahead.
Yeah.
So do ask your question. Do you have a question, or did you want to make a comment?
No, I wanted to make a comment.
Please go ahead.
Yeah. So just I want to highlight that WHO in 1978, that was the time when they were classified as lesions and conditions. So it was 2008 when they named it as pre-malignant disorders. But this term, the new term, the oral potentially malignant disorders, it has come recently only in 2017. So the reason being, there is only a statistical chance of progression. So they thought that OMPD is better suited because it just suggests that progression to malignancy is only a potential risk. They are not the 100% pre-malignant.
Okay, the point well taken. So,
Doctor,
yes,
yeah.
Dr. Indu. Yes, ma'am.
I want to ask Dr. Shefali. Dr. Shefali, do we need to understand the arterial supply of the tongue? Does it have any implication for further treatment, say for radiation planning or for recurrent cancers?
Yes, ma'am. So it's important to understand the arterial supply because tongue, as we know, is a highly vascular structure. And especially if we are planning treatment radiation, for example, say with brachytherapy. So there is a propensity of hemorrhage. So it's important to understand the blood supply.
Hemorrhage happen. What will cause hemorrhage? What is yeah? What is the arterial supply of the tongue, Dr. Shefali?
The arterial supply of the tongue is through the lingual artery, and which is a branch of, and also the ascending pharyngeal artery. So predominantly lingual artery. Yeah.
Ascending pharyngeal artery.
Predominantly lingual, but minor supply through that as well.
Okay, and what about carotids? Have you ever heard about carotid blowout or something? So
yes, ma'am.
So isn't that important too?
Yes. So carotid blowout is especially important for the recurrent tumors in which we are treating the patient with re-RT, and we have to provide the constraint to the carotid because of the risk of blowout, and also in locally advanced tumors with the massive lymphadenopathy, there is a risk of carotid blowout, so we need to take that into consideration.
Okay, so lingual artery is a branch of external carotid artery. Okay, it comes between the superior thyroid and facial artery. Okay, at the level of greater cornu of the hyoid bone. It arises at that level. Okay.
So I think Dr. Haresh had beautifully described the vascular anatomy of the tongue, and the clinical significance is of knowing this for yourself also, because as ma'am mentioned, if a patient starts to bleed and patient has a hemorrhage, sometimes you might request for a embolization or a ligation. So it is important to understand the vascular anatomy. So
And I want to raise one point here that nowadays, like when we do contouring for breast cancers, then we are very much worried about LAT and all. But nowadays, a lot of emphasis is being put on the late side effects because of radiation to these minor vessels, and it can lead to lingual artery stenosis. Okay, so that's why it's very, very important to understand the anatomy of head and neck, because there is some data emerging which says to prevent long-term toxicity like stroke. So these patients who have earlier history of, say, smoking or alcohol, or they have other cardiovascular risk factors like in this particular patient, then maybe we should consider use of aspirins or antiplatelet agents to prevent long-term stroke. So this is also something that is an emerging field, and we should keep that into account. Although we don't talk much about cardiovascular toxicity post-radiation to head and neck cancers, but we have long-term survivors now. So we need to document. Yeah.
So moving forward, Dr. Pooja, can you just enumerate briefly what would be the risk factors for development of oral cavity tumors?
Ma'am, various risk factors for development of tongue cancers are smoking, then ill-fitted dentures, alcohol consumption, betel nut consumption.
Yes, please go ahead.
Like pre-malignant, if there are pre-malignant lesions, they can also cause like dietary deficiencies.
So I think as students, most of us kept that mnemonic of S. Spice, sepsis, sharp tooth. So I think it would be handy till date to use that mnemonic so that you can enumerate all the possible risk factors for oral cavity tumors. So let's not spend more time here and move forward with the case. So Dr. Grishma, now this patient has come to you and coming with this tongue lesion with a biopsy which is well differentiated squamous cell carcinoma. Now what will be your management paradigm? Now how would you manage this patient?
Good evening, ma'am. Ma'am, this patient is a biopsy proven tongue malignancy. Stage is clinical T1N0. So first I would do either CT or MRI of the face and neck for local extent, and for metastatic workup, since it's an T1 disease, I would do a chest X-ray and the routine blood tests and all for further workup.
So I would love to see your videos as well. It is good to be visible when you're speaking. It is your own community. Don't hesitate. Okay. Okay.
Yes,
So,
ma'am.
so you mentioned that the set of investigations you would do would be. So I think it would be a good idea to speak of these investigations first for establishment of diagnosis, then staging, then metastatic workup. So, what would be the preferred imaging? What imaging did you choose for this particular patient?
Ma'am, CT scan of the face and neck and chest X-ray.
So does the surgeon on the panel agree with the CT scan, or he differs to what she says? Dr. Vikas, are you happy doing a CT scan?
Ma'am, I would like to do MRI, contrast enhanced MRI from base of skull to the clavicle. But I would like to add on one point also, as this is superficial tumor of T1 lesion. Many surgeons still are not preferring any imaging modality for a T1 lesion. That because for T1 lesion, any imaging modality is not required. For so some surgeons prefer that practice also. But I would like to do contrast enhanced MRI.
So anyone from the radiation side in the panel who would be happy getting a patient who did not have a pre-op MRI, or would you want to justify a pre-op MRI in this patient?
I would definitely go ahead with a contrast enhanced MRI. That is the bare minimum that we should do for the local evaluation of the disease, and also to look out for any cervical lymphadenopathy which was not palpable clinically. And it gives a better estimate of for the submucosal invasive component of the disease. And even though it's well palpable disease with a size of 1.5 into 1.5, if there are no logistical issues, why refrain from doing an imaging?
Okay. So what would you prefer, Dr. Vikas, if you're looking for lymphadenopathy in the neck? Is still MRI would be your investigation of choice?
If you are asking about, so MRI is sufficient for that. But if you are asking about which is the best for sensitivity and specificity, so Lau et al. In 2002 has published a paper in which he took N0 and in which sensitivity was similar for all four parameters of CT, MRI, PET, and USG, but specificity was higher. Specificity was higher for CT scan in clinically N0 neck. So yeah, specificity and sensitivity is higher in CT scan, definitely. And this Bond et al. Paper was published in 1996, and he took N0 plus N plus neck. So
just to reiterate,
USG FNA was highly specific for it.
Yeah. So just to reiterate to your fellows, Dr. Pooja, can you tell us what actually are we talking of when we talk of sensitivity and specificity? What is it indicative of?
Sensitivity means, ma'am, true positive, and specificity means, ma'am, true negative. So in CA tongue, like in this article, we can see the sensitivity of USG guided FNAC was around 0.80, and specificity, that is true negative, that is 0.98. So this means that so specificity, like true negative, it is showing us like the USG guided FNAC showed us like a point, it has highest value for telling us like it the conditions in which the patients in which the test will be positive and the patients in which the test will be negative.
Yeah. So now coming back to Dr. Vikas, so the treatment options, of course, if this patient would land on your table to start with, so what would be your treatment options which you will talk about, and what will be the type of surgery? We heard a lot about the compartment surgeries, the hemiglossectomies. So please, in very brief, let us know what would be the surgery which will be undertaken for this patient.
Dr. Kanika, can I interrupt? My point is some of these students, when they take up they will get such cases in the exam. They should not be seeing PET scan for a T1 N0. I think that needs to be emphasized.
Yes,
And if
absolutely
they have
agreed,
a
ma'am.
single modality, then I think MRI is good enough. to take care of both the primary as well as the nodes.
Yes, I think that is one of the take-home pearls they should be taking home, that the amount of information the MRI is giving in oral cavity head and neck cases is good enough to take decisions on surgery. It is giving us a reasonable information on lymph node involvement and also helps in radiation planning, which is the answer I was seeking from
Also,
the.
I want to emphasize, would you be happy only with X-ray chest or you would do a CT chest? PET nobody would do in a T1 lesion. But would you be happy operating with this, with just an X-ray chest?
So yes, Vikas, tell me. First you tell us. And
T1 N0 chest X-ray, I think should be good enough.
So I want to know from Vikas.
Just giving it a thought. So what is the practice? What is the practice? Don't think of literature. What is your practice? Do you do in routine CT chest for T1 N0? Done? I think Vikas has just frozen. He's trying to reconnect.
Okay. Another thing, Kanika, which probably needs to be emphasized is detailed clinical examination, including palpation.
Yes.
And documentation with the diagram or a photograph about extent of involvement into the floor of mouth or adjacent gingivobuccal mucosa, etc. That has to be distance from tip of tongue.
Absolutely. The anatomical charting is very, very critical, especially even with the sectional imaging. The mucosal disease extent is sometimes not appreciable. So the diagram of the surgeon would form the basis of a lot of things. So it is very important. That definitely is another take home.
And I think one thing which is also very important is whether the lesion is infiltrative or it's an it's an exophytic lesion or an endophytic lesion. Because for an endophytic lesion, I think MRI would be definitely better than a CT scan for the neck. We never know how creepy the tumor would be inside. And
so soft tissue delineation and soft tissue is irrespective of the type of growth. I think soft tissue delineation MRI scores better over CT scan. So I think Vikas we've lost. So I think in a routine practice, even T1 N0, most of us are happy going ahead with X-ray chest as well, unless there are other adverse factors to justify going for a sectional imaging of the chest. Dr. Vineeta, would you want to give an opinion on that?
Can you just repeat?
So I said for T1 N0 and clinically N0, most of us are accepting X-ray chest as a metastatic workup in addition to an ultrasound upper abdomen if indicated, unless there are other adverse factors to justify a CT chest.
I agree, Kanika. If there is a nodal positivity, then I'll be more inclined to do a CT chest. Or sometimes if the patient is a heavy smoker, and you want to rule out any other second primary, then also you would be inclined to do a CT chest. Otherwise, generally chest X-ray would be sufficient. In fact, ultrasound of the neck is also a very good modality for doing the regional imaging, but then it is an observer-dependent modality. So that has to be always remembered.
So I think, ma'am, we've lost Vikas from the panel.
No, ma'am, I joined.
Back.
Actually, there was internet problem.
Right. So, Dr. Manish, would you want to ask Vikas a few more clinical details with regards to the surgical planning and the extent of surgery?
In this imaging, we can assess the depth of invasion, like MRI is useful for assessing depth of invasion radiologically. So it looks like it is more than 5 mm. So it should be clinico-radiologically T2 lesion, T2 N0 lesion, if there are no MRI detected lymph nodes. So that will add to our management of neck also. Like thin lesions versus thick lesions can be delineated on the MRI for these smaller lesions.
So Vikas, what would be your plan of surgery for this patient? Can you just in a very short answer tell us what would be the surgery?
Ma'am, I would like to do treatment of choice will be wide excision with neck dissection, modified radical neck dissection.
So can you specify the neck dissection, unilateral, bilateral?
Ipsilateral modified radical neck dissection with the wide dissection of the primary lesion.
What do you mean by wide excision? How much margins?
Ma'am, I would like to do with the 1 centimeter margin, but 0.5 centimeter of gross margin is acceptable in the wide excision.
You are aiming at pathological 5 mm or a gross 5 mm on table?
Pathological 5 mm, sir.
So for that, how much margins will you take on
So
table?
at least 1 centimeter.
At least 1 centimeter.
So I
Ma'am,
think,
I have a question.
please go ahead.
Ma'am, I just want to ask that ipsilaterally, if we are going for modified radical neck dissection in case of tongue, since if it is a T2 lesion, then nodal positivity can be up to 30%. So will we go for the contralateral supraomohyoid neck dissection, or only we will confine to the ipsilateral?
So we won't go for contralateral neck dissection unless the lesion, because if ipsilateral it is clinically N0, data suggests that contralateral neck is having less than 5%, 2 to 4% positivity rate. So in that case, we won't go for contralateral neck dissection unless lesion is midline crossing. Lesion is midline crossing or reaching up to midline.
Thank you.
Or it's in the anterior tip of tongue.
True, ma'am.
Yeah.
Another question is that what is the disadvantage of doing bilateral neck dissection? What is the
Ma'am, we
morbid?
are not. It's less morbid condition, but there is no benefit of adding contralateral neck dissection in T1 or T2 and 0 case.
Dr. Vikas, I want to ask you, what is the minimum yield that you want to get when you do a neck dissection? I mean, how many lymph
pardon,
nodes
ma'am?
do you call an adequate dissection?
So there is no definition.
So in numbers, ma'am.
So there's a paper by Ibrahimi et al. Where they said that, I mean, I tried to locate that, where they said that if at least 18 lymph nodes are removed, it's considered an adequate dissection. The surgeon would, I would like comments from the surgeon here, Dr. Manish.
Ma'am, it depends on the type of patients we are operating on. It definitely will remove all but it depends on the pathological grossing also. There is no recommended, there's only one paper which we are quoting, which comes up with this number of 18.
Yeah.
But
so if suppose, Dr. Vikas, if suppose you come with a pathology report which shows that 8 lymph nodes removed, or say 5 lymph nodes removed, would you call it an adequate dissection, or you would request your pathologist to go for more extensive grossing and do more lymph node dissection, or the radiation oncologist here, would you discuss with your surgeon regarding adequacy of the lymph node dissection, or you would be happy with that report? 0 out of 4 lymph nodes positive.
So, ma'am, in surgical team, if we are sure that we have removed all the lymph nodal stations, all the lymph node levels, then I would like to say pathologist to revisit the case again.
this problem is caused when your specimen 1 to 5 is sent to pathologist as a single specimen. So what we do at our institute is we send level 1A, level 1B, 2A, 2B, 3, 4, 5 separately. So we've got various stations. So even if they find 2 to 3 lymph node, that accounts to more than 3. And those which are enlarged lymph node, they are sent as separate. So that can increase your yield.
So I think in the interest of time, we should move forward, because we know we don't have any such criteria based on lymph node numbers as of now in the guidelines. So Dr. Shefali, had this patient landed to you instead of Dr. Vikas, what would be your treatment line would you offer? Would you be prompted to offer him radiation in form of brachy or EBRT, or go ahead with the surgery? Dr. Shefali?
So in this particular scenario, I would also like to offer the non-operative management to this patient. And for him, I would like to offer external beam radiation therapy followed by a brachytherapy boost. And had it been a T1 lesion, T1N0, then the option of radical brachytherapy alone is also feasible. And in case it's a T2 disease, assuming from the imaging that the depth of invasion is greater than 5 mm, then external beam radiation therapy to address the entire tongue and the lymph nodes, followed by a brachytherapy to address the gross tumor. So that would be one of the options.
So if you're planning brachytherapy and you're planning EBRT to start with, so how would you proceed? How would you ensure that the implant which you do post EBRT is actually taking care of the initial disease? So what are your steps? What would be your plan of care?
Okay, so first and foremost, adequate physical examination and the local examination of the patient and good documentation of the same is important. And then the imaging needs to be considered very carefully. And again, first, I would like to begin with the EBRT to a dose of 50 gray in 25 fractions over around 5 weeks at a dose of 2 gray per fraction, and then follow it up with the brachytherapy. And in that scenario, I need to include for the brachytherapy, I will include the entire gross tumor along with a margin of 1 centimeter around it. And that has to be covered with the interstitial implants with the submental approach. So
the dose fractionation? Dose fractionation for the boost?
So for the boost, I would like to go ahead with a dose of at least 18 to 21 gray over around 6 to 7 fractions twice a day, 6 hours apart. With the high dose.
Okay. So in case it was a T1N0 lesion, so what would be the dose scheduled for in that situation?
For T1N0 disease, if I'm going ahead with the radical brachytherapy, then the dose of 60 gray at 5 gray per fraction twice a day, that would be my dose. But if I'm giving a brachytherapy boost, then somewhere in the range of 15 to 20 gray twice a day fractionation. That is what I would go ahead with using as a boost. So actually this case is pretty is a good candidate for going ahead with definitive radiation because 69-year-old male with past history of MI with the EF of less than 50% and other comorbidities. So it's quite likely that the patient could be deemed inoperable. And also because of decreased morbidity and overcoming the surgical complications and better functional and cosmetic outcomes. So definitive radiotherapy can definitely be given as an option.
When you're counseling this patient for brachytherapy, what would be the projections of outcome which you will tell him?
Okay, so as of now, there is very good humongous data regarding retrospective data regarding the outcomes of local control with brachytherapy, which are comparable to surgery. The lacking part is definitely the prospective data with the head-on comparison with surgery. And but the outcomes are definitely good. The patient has a small lesion, and it is going to help with better cosmetic outcomes, with better functional outcomes. There will be no speech impairment, no swallowing, deglutition difficulties, and also it's more feasible, more pocket friendly for the patient, and less morbid than the surgery.
Okay, I think we have a lot to discuss, so we just want to move forward. If this patient gets operated, so Dr. Shefali, you're there?
Yes, ma'am.
Yeah. Okay, I'll pose it to Dr. Garima now. You've been answering quite a lot. So Dr. Garima, now if this patient gets operated, what would be the indications for adjuvant? What would be the indications, and what would be the indications for the concurrent chemoradiation? Could you just enumerate them?
Ma'am, in case of this T1, T2 lesion with no cervical lymphadenopathy, for the adjuvant setting, postoperative radiotherapy, we will see that is the depth of invasion post-op. That if it is in our institute, we follow the depth of invasion more than 4 mm and the post-op tumor size is more than 3 centimeter, then we go for adjuvant radiotherapy, 60 gray in 30 fractions. And if PNI is positive, if LVI is positive, then also we consider giving adjuvant radiotherapy to the patient.
So you said more than 4 mm depth of invasion and size 3
and
centimeters. So
tumor size more than 3 centimeter in case of T1, T2, in case of T2 lesion of the anterior oral.
So can you substantiate your answer with some studies which you are aware of?
Yes, ma'am. The famous study of Bonner and Cooper in RTOG and EORTC trial, they have mentioned that the post-op RT settings, the PNI or T3, T4 lesion or lower neck nodes or more than 2 lymph node stations are if involved and PNI is positive, then we go for adjuvant RT. And in case of T1, T2, first step is surgery. If there is a contraindication for surgery, then we go for radical RT or brachytherapy. And in case of post-op histopath showing positive margins or extranodal spread of disease, then we go for concurrent chemoradiotherapy in adjuvant setting.
Dr. Garima, you would give radiation for a 3 centimeter tumor if there are no other risk factors?
More than 3 centimeter tumor and depth of invasion more than 4 centimeters.
If the depth of invasion is 4 mm and the tumor size is say 3.5, you would give radiation. No other risk features. Depth of invasion 4, tumor size 3.2. What literature do you have to support this recommendation? 3 centimeter
In case
tumor
of
size.
the risk factors, it's 2 or more than 2 risk factors if are positive, then we go for post-op RT in oral cancer.
So 3 centimeters, I don't know from where did you get this figure. I'm surprised to hear this.
So I know, I am aware that there are institutions which have a policy of treating lesions beyond, even T2 lesions based on their clinical experience and the department protocol. But definitely the article which you spoke of, I think that does not mention the usage of RT for 4 mm and more than 3 centimeter size. Definitely you can justify your department protocol in the exam, but you need to give a basis on the evidence which has made you prompt this answer in your exam. Unless you are justifying with that, the answer may not be acceptable to all examiners.
So I think Dr. Kanika is trying to say that, Dr. Indu is trying to say that you have to give an evidence-based answer in your exam and not protocol which is followed by your department. Sometimes that may not be acceptable by your examiners. You have to give, they will ask you to give them the evidence. Kanika, I'm sorry, but now we need to close this.
Yes, ma'am. I think because Vaibhav has created a very elaborate radiation protocol slides, which would be just not be visible, feasible to finish off. So I think we have covered most of the indications, and quite a lot of things were discussed during the individual presentations as well.
And give the message.
Yeah. So I think what we need to understand is we should be clear onto what are our indications for radiation. We have to optimize the patient, irrespective of whether you're doing radiation or concurrent chemoradiation. Before starting treatment, it is important to optimize your patient, take into account the performance status of the patient. And there are certain set of tests which should be done before initiating treatment, which include pure tone audiometry. If you are getting a concurrent chemotherapy, you should get a dental evaluation done, irrespective of the dental status of the patient. Even if patient is edentulous, he does require an evaluation because there may be some gum-related issues. Nutritional assessment should start before starting treatment. The nutritionist should be part of your team before starting treatment. So should be the the speech or the physiotherapist, so as your patient can start off treatment with swallowing maneuvers to right from the beginning of the treatment.
Kanika, one point. If you use this word in your exams, which Dr. Kanika has just now said that I will start with optimization of the patient for radiation therapy, the examiner will be impressed. And actually that is what should be done in the clinical practice also.
Because most of the times we forget the smaller things and we look at the bigger picture. And many a times patient himself might consider dental evaluation as unnecessary. It is your responsibility to ensure that all these referrals and consults are done before initiating the treatment. To ensure that the treatment goes smoothly, these are the essence of optimization. So I think we've talked of the, Akanksha has spoken about all the parameters of chemo, but one important thing we want to know is that when should be the adjuvant treatment started? So for head and neck, there is no hurry to start before 4 weeks. It is 3 to 4 weeks is the ideal time when suture healing is adequate and the surgeon gives the go ahead when treatment should be started. But beyond 6 weeks, this particular slide is showing that if you delay treatment beyond 6 weeks, with every passing week, there is a reduction in local control to the tune of 7 to 8%. If you delay it much beyond 8 weeks, the locoregional control falls to 51% from 87% if you had started the treatment well within time. And this is again, which he was talking of the risk factors. Dosages have been spoken about. I think drug, again, Akanksha has spoken about. And this is about the counseling, which again formulates the very important part of your patient planning, where you are giving them instructions to follow during the course of treatment. So I will not go through them. And ma'am, rest, I think he was talking more of, about the planning aspect, which we can, I think, skip now in the interest of time.
Can I make one comment here?
Yes, surely, ma'am.
I want to ask the surgeons, actually, I was reading through papers and we have not talked about lymph node ratio, which is also emerging as a very important parameter, means the number of lymph nodes removed positive versus the number of lymph nodes positive. So some data says that for definitive radiation, if the lymph node ratio is more than 10%, then also it warrants radiation, although some data is emerging that's not a standard guideline. And for salvage radiation, means when surgery has been done and you're giving adjuvant radiation, then the lymph node ratio, if it's more than 6.5%, it warrants bad prognosis. So I think now we should also start looking at lymph node ratio, although there is no specific of course, I mean, that warrants a bad prognosis. I just wanted to make a comment here.
Usually the dictum is anything which is more than N2 is bad. So I think that has been captured as an intermediate risk factor in the NCCN as well, if there is more than 2 lymph nodes, more than N2 disease.
Yeah.
So over to you, Dr. Vineeta, ma'am. I think we can wind up the proceedings of the day. It has been a great opening though.
Yes, we are all very happy and excited. Thank you all the participants. Thank you all the panelists. Thank you, Dr. Kanika, for pitching in at the last minute. And thank you, Dr. Indu and Dr. Manish Gaur for your expert comments. I think this session has been very interactive, well attended. And let me tell you all that Oncology Forum intends to continue such educative online sessions on this Zoom platform. And we expect that we will have more such discussions on varied cancers. I request all of you to become a member of Oncology Forum. You can go to the Oncology Forum website and apply for membership so that you keep getting the information about these meetings. And I have shared my number in the chat box. If any one of you are, as students, you are interested in participating actively by doing some presentation or being a panelist or case presentation, etc., please share the information with me on WhatsApp, and we'll make sure that in the future meetings you do get a chance to present and participate. And another thing is that the next session of the Oncology Forum classes now will be on the 14th of February, which is 2 weeks from now on Tuesday. And the topic is management of oropharyngeal malignancies. And it will be conducted by Dr. Rashi Agrawal from Max Hospital, Vaishali. And you will all keep getting information about it. And once again, thank you everyone for sparing out your valuable time. My special thanks to Mrs. Nidhi Mittal for organizing this whole event. Thank you all and good night. Kanika, you want to say something?
I think, ma'am, we need to keep the momentum on, because learning is a continuing exercise. More than what you all learned, I think we all also learned a lot today. So it is not just the residents, even as consultants, we had a great learning experience today, and we need to continue this so that our patients benefit from all the advances which are coming in our other fraternities as well, because we don't know what is happening in surgical fields, we don't know what is happening in the medical oncology if it is of not our interest. So this is one platform where we get to know what is happening in the entire field in totality. So please keep posting your suggestions also. If you want something, if you want certain classes, we will be more than happy to facilitate those classes as well.
Dr. Indu, anything from your side?
I just want to congratulate both of you for doing an excellent job today. And I think as Kanika said, that I think it's a very great learning for all of us also, because we also come to learn so much from the students, because I think when they come and present something, they are most well-read than even us. So I really want to thank all the speakers and the younger generation who participated, and all my peers and colleagues from which I learned a lot. Would be looking forward to such classes, and good job by all of you.
Thank you. Thank you. Good night.
Thank you.
Thank you.
Good night.